Good morning, everyone. Welcome to day 2 of Amrita Craniofacial Update 4.0, Interdisciplinary Discussions in Craniofacial Surgery. We're hoping to make this day as engaging as insightful as yesterday. Without much delay, we begin with the sessions for today. The first one on management of hand and feet anomalies associated with craniofacial syndromes by Dr. Vasundhara Jain, plastic reconstructive surgeon from Amrita Hospital, Faridabad.
Good morning. I'm Dr. Vasundhara. I'll be talking on Good morning. I'm Dr. Vasundhara Jain. I'll be talking on management of hand and feet anomalies in craniofacial syndrome. So a lot of the data that I'm going to be showing is from Amrita Kochi, because I was fortunate enough to do my post-graduation MCH here, and a few cases that I've added from Amrita Faridabad. So just a general overview of all the deformities associated with craniofacial syndromes. Apert is what we talk about the most, in which complex syndactyly is very commonly seen. Other than that, you'll see synostosis, some deformities of shoulder, elbows, and Pfeiffer syndrome, you'll see broad thumbs, broad great toes with radial deviations. There are some cases where polydactyly might be seen along with syndactyly. Few, like in Munke syndrome, you'll have fusions of the tarsal carpal bones. So few images. The first one is a syndactyly of hands and feet and aperts. The second one shows the radial deviation of the great toe and the thumb. And the third is an X-ray showing the radiohumeral synostosis of the elbow joint. So we'll discuss the deformities of aperts in a little bit of detail. So this is a combination of craniosynostosis, hyperplasia, and severe complex syndactyly. Clinodactyly, which is basically a deviation of the finger, is also seen in these cases. So it's classified broadly into three types. The first is a spade hand, where the thumb, the first web space, there is an incomplete simple syndactyly, by which I mean that there is a joining, but it's a soft tissue joining of the first web space. There is no bony deformity in that case, and the rest of the central mass is usually a flat mass in a planar surface. The second one is a spoon hand, which is the first web space is a complete simple syndactyly where the entire web space is fused, and the central mass, the digital mass, has a palmar concavity to it. The third, which is the worst, is a rosebud hand or a hoof hand, which is a complete complex syndactyly where basically the entire hand is fused and it's a cupped hand. So the management, it's basically before 2 years, you should aim to release all the digits. And the ideal period is the first stage around 9 to 12 months and the second after 3 months. If there are minor web space narrowings, those can be managed with local flaps. Clinodactyly, which is basically a deviation. Sometimes you may have to do a osteotomy with or without bone grafting. And feet, it's a debate between people whether they choose to address it or not. We choose to address the first web space so that the children can wear footwear. So the first image is showing a spade hand. The second one is of a rosebud hand. So these are few deformities. So as I described, syndactyly is basically the fusion of a soft tissue or the skeletal elements of the digits. So this can be either just a simple syndactyly or it can be associated along with other deformities like polydactyly, which is multiple digits, clinodactyly, which is deviation of digits, or brachydactyly, where there's shortening of a part or the entire digit. So the problem here is if the first web space is fused, then there is no grasp of the hand. There is no pincer grasp. The span of the hand is short, and that's what happens with the digital motion gets hampered if there is a fusion of the other digits. Plus, if there is a fusion between two digits of different length, there'll be some contracture of the joints. These are the X-rays showing the same. So depending on the deformity, we choose to do the procedure. Just a basic overview of the other deformities. Clinodactyly is when there's a more than 10-degree angulation. If it's mild or to moderate, no treatment needs to be done. But if there's substantial, then you may have to address it with a wedge osteotomy. And thumb clinodactyly is what's seen in Apert syndrome. This is a case we had recently done where the middle finger was addressed and straightened. Brachydactyly is basically shortening. That now it depends what the functional and aesthetic impact of this is, what is the extent of the shortening, how many digits are shortened, and what is it associated with. Usually it's definitely addressed when there is syndactyly. Most commonly, it affects the middle phalanx, and the small and index finger are commonly affected. And if you need to address it, you usually do either you can do a distraction, which is basically doing an osteotomy and distracting the finger to maintain its length, or you do a bone grafting. Now, some people are enthusiastic about addressing it, but usually it doesn't need to be addressed because sometimes it can cause joint contractures and stiffness when it's not necessary. So we will focus on the management of syndactyly. It needs to be coordinated with the the cranial part, the cranial surgery that has to be done. So usually, if it's a complicated syndactyly, it needs to be addressed in 2 stages. So we've just analyzed our cases, which we've collected here, which were done in Amrita, Kochi, and so we collected 13 patients. All of them had X-rays of the hand and feet prior to the surgery. It was a standardized zigzag incision with so on the dorsum, you take a flap so that that can be inset into the web space. Otherwise, that will again get contracted. And most of them were covered partly by the flaps and partly by the full thickness graft taken from the groin. And this is an example of a case where the release has been done and it's been closed with FTSG. In this case, because the child had the component of craniofacial as well, so in this wedge osteotomy and straightening of the digit was done. So this is just a 2-month follow-up of this kid. He started to use the hand, but he's not using the 2 individual digits completely yet, is what I've been told by the mother. So this is another child who had come. He'd already come from outside. They had already gotten the 4th web space done, and the first web space release is what we had planned for them, which was partly closed with flaps and partly by full thickness graft. So these are few more results of children. So we have done a release of the first web space for some children, and in that either it's covered with the skin graft. So in our cases, most of them, out of the 13 cases, 7 had bilateral complex syndactyles, and 2 had the first web space free, and 1 patient had a polydactyly associated with the complex syndactyly, and 2 patients had simple syndactyles. And out of all the kids, there were 3 that didn't have feet anomalies, 6 had bilateral simple syndactyles, and 4 had bilateral complex syndactyles. So out of all the children that we analyzed, 10 were and we had, so all of them at least had 2 stages of release, and in that we choose to release the first web space and the 4th web space first, and then in the second sitting either the 2nd or the 3rd web space, and in that same sitting we release the first web space of the feet. So we've seen that usually the process is that you do alternate web space releases, but we found that in our practice, when we do the first stage, 2nd or 3rd web space release, it doesn't give a very good function. So that is why we choose to release the first web space, free the thumb, and the 4th web space, so that the 2 digits, which have different lengths, are separate, so that there is no deviation, no contractures. So few long-term follow-ups of children. This was a child with a bilateral complete complex syndactyly. This is a person who had a bilateral simple syndactyly. Again, one with complete complex syndactyly. And this is a girl who the first web space release was done for her. This is another kid. This was a complete complex syndactyly where all web space releases were done. So it is a more complicated syndactyly and craniofacial syndromes, but if we do it at an appropriate age, it gives good results, and they're able to carry out good hand function. And if you release the first web space, they're able to wear all types of footwear. Thank you.
Thank you, ma'am. Any questions?
Thank you, Vasundhara, for coming down and giving that talk. And I mean, when we say craniofacial, we often, disregard, or it doesn't come into our, eyes, the other deformities that occur with these children, and it's a very great work that you have done, and with ISR, of course, but then it makes the children better, like the way what we do for them. But at a more practical level, all these hand and feet anomalies are very well taken care of. Thank you so much. Next, we have Dr. Maria Kuriakos. These are people who are allied specialities who work in the background, but then do very important work. Dr. Maria has been with us as an orthodontist for the last 22 years. And she's not a regular orthodontist. She's a surgeon's orthodontist, I would say. More than 90% of her work is surgical orthodontics, where she prepares patients for their jaw surgery. More with cleft, but she sees all our craniofacial patients as well who have mid-phase issues. Dr. Maria?
Good morning. You can actually start it up. Yeah, I'm the person, the orthodontist, and I've heard often at conferences saying that please don't refer the patient to an orthodontist, because if you give the patient to the orthodontist, the treatment never finishes. But there are reasons for that, and I will explain some of the difficulties we have in dealing with these patients. So what is a craniofacial orthodontist? Basically deals with the musculoskeletal system within the craniofacial area and the associated sutures, and our job is mainly to monitor growth, diagnosis, treatment planning, and orthopedic or orthodontic treatment of the craniofacial disorder. So these are some of the common common deformities that we see. There is synostosis, which is cruzone and apert. There is achondroplasia, cleidocranial dysplasia, and then Somia Treacher-Collins, Goldenhar, and Binder syndrome, Barry-Romberg syndrome, muscular hypertonia. You find that it covers a very vast area, and you get all types of cases here. An example of cruzone syndrome, example of apert syndrome, and according to the updated guidelines, when is a patient supposed to see an orthodontist? Or a dentist to start off with. So at age of 4 years, when they have, basically you teach them about oral hygiene. 6 years is when you start monitoring growth when the first molars start erupting. 9 years, you check midlines, habits, and if expansion is needed. 12 years when you have the second molars erupting and you look at whether there is anything changing. 15 years when you have the permanent dentition, and 17 years is when you start preparing for any orthognathic surgery. So what are the problems that we associate with all these syndromes? So it is most of the orthodontic and dental problems that we have is mainly because of the abnormal growth of the maxilla. And there is in the vertical, transverse, and sagittal directions, and leading to a maxilla which is hypoplastic in all directions. So what does this hypoplasia lead to? So what you have is that you get an anterior crossbite, an anterior open bite, bilateral posterior crossbite, unilateral crossbite. You have ectopic maxillary permanent molars erupting, and deviation of the midline of the dental arches. Now these have significant consequences for us as orthodontists, because we have to look into all of these. So we'll come to that a little bit later. And in patients with Apert's or cruzone syndrome, the dental arch may not widen during growth. Again, this has a lot of influences for us. Large lateral gingival swellings are also found in these patients, and this usually increases with age. A bifid uvula is also found in almost 75% of the patients with Apert syndrome. And in summary, what do you find? In cruzones, you find a small maxilla, which means that the translation of the maxilla during growth and development has not happened. There is severe crowding, ectopic eruptions, missing teeth, thick fibrous gingiva, mucus, saliva, anterior open bite, and tongue thrust. In apex, in addition to everything that you see in croussons, you also find lateral swellings. There is a short, hard palate and a long and thick, soft palate. Incidence of cleft palate is there. The posterior nasal spine is down, which means that you have to take that into consideration when you're planning your orthognathic surgery. Counterclockwise rotation of the palate, high mandibular plane angle. There is mouth breathing, gingival hyperplasia, and with the short maxilla, what happens is you will get sleep disorders. OSA is a problem, ear infection is a problem, respiratory problems, and when you have an anterior open bite associated with that, you have a lot of habits that develop. So we have to look into those too as we start treatment. Now, challenges for the orthodontist. In apex, what you have is actually a mutation of the fibroblast growth factor receptor 2. And as a result, this affects the fibroblast. And normally what you would find is very thick fibrous gingiva and gingival hyperplasia. Now in apex, another problem is they have, as Vasundhara was talking about, syndactyly, and so their manual control is also very bad. Oral hygiene is bad. So a combination of this makes orthodontic treatment really difficult. And most of these, especially in apex, you find that they are mentally, may not be up to the mark. There's some of them are mentally challenged, which means that teaching them oral hygiene regimes doesn't work. So a lot of onus is on the parents to help us out. But again, kids being kids, they come back with broken brackets and you ask them and said, I chicken, so something came off, I just threw it out. So that bracket is gone. So we have to go and look for another bracket. So we deal with situations like that. And one of the reasons why our treatment gets delayed is because of this. Now, the other challenge that you find is that the occlusal plane is at different levels. And in normal orthodontists, it's very common, which we do. We just use a single arch bonding single wires. But in this case, when you have the occlusal plane at completely different levels, you have to use sectional orthodontics. More demanding, more time consuming, and the control of movement is also much more difficult. And as you can see in this, you have gross midline shifts, which means that you have to make the space for it. Gingival swellings again. So this is a situation where you have the gingival swelling and this was removed. And the third picture is actually when you get the palate with the gingival swellings removed for orthodontics. Now, as I mentioned before, growth of the maxilla does not happen. So you get expansion is very difficult. And so we have to we have to think of ways in which we can do this, and one of them is SARPI, where you actually make the cut in the midline so that you can expand. Other things that you think of, you think out of the box. So I talk to the lab technicians quite a lot to see whether there are new screws, what has come up. So these are things whether you can use two Hyrax screws at the same time. So in this patient, what we have done is we've used a micro screw initially, got a little bit of expansion, and then put another screw so that we could get the expansion. Ideally, the one thing that would be great is to use a bone expander, but that again works out to be very expensive. So it is not possible for all the patients. Again, you might not get bone everywhere, so you have to arrange the teeth where the bone is. So now for this, you need to coordinate your work with prosthodontist. So you arrange the occlusion to where the bone is. And if you look at the last one where it is, you can see that the teeth are kind of splayed. That is mainly because we have put the teeth where the bone is. So you can see that there is actually the roots that are not parallel, they are divergent. Post-surgery, what are the complications that you have? Like normally you know of the treatment plan and that you know that after LeFort 3 you do LeFort 1. And then what are the complications you get after the surgery? A lot of them don't have muscle coordination, so each time you see them, you have a different bite. So trying to get them to one single bite, so that is what you call a sunder bite, which is that they bite differently at each different occasions. So that is what you find, and trying to get them to coordinate to find a single occlusion is again challenging. It takes a long time to get that. Habit breaking appliance, as I said, when the maxilla is short, small, and it is deficient in all dimensions, you develop a lot of habits. Though you go through orthodontics before the surgery, again after surgery, a lot of these habits come back, and after surgery, you find that you have to include a lot of habit breaking appliances sometimes. So this is what you would find, the initial and after LeFort 3 and after LeFort 1. So these are kind of some of the difficulties that you encounter when we do so you start off with something like that which you see in the first 3 slides, and you finally after LeFort 1, that is kind of the occlusion that you get. But again, maintaining oral hygiene is quite a task with these patients. Very unique case that we got recently, unilateral coronal synostosis. Usually we don't see this in an adult because they are usually corrected as children. Here basically what you find is that a whole twisting of the face where there is stenosis, the maxilla will bend towards where the stenosis is, and the mandible will grow in the opposite direction. So you will get deflection of the nose as well and of the whole face. So this is basically what you would get. So the whole face becomes twisted, and nowadays, which is something which is very common, you get these patients coming and saying that in 6 months' time, I'm going abroad, a very common phenomenon. So a lot of the times we are forced to do surgery first, and Pramod is never says no to a challenge. So we did surgery first for this, and this is what we got immediately post-surgery. So she just didn't have a bite, she couldn't bite, and that is what we got immediately. So that is what I had to do, kind of give almost three or four elastics on each side. And to compound everything, after a month, she said that she wanted to go to America for a month. So she was off. So I had to give her all these elastics and asked her to send me videos. Please send me videos. Are you wearing the elastics? And they're teenagers, they are not bothered. Sometimes they wear the elastics, sometimes they don't. So they come back, and she came back. But she is studying now in Singapore, and she comes kind of every 3 months. So we just saw her recently in December. And this is what her occlusion is. She's looking quite nice. She's become very confident, very happy, enjoying her college life, but still a little bit more. At least I've got one side done. The last side, I just need to do a little bit more before I can settle the occlusion. Just thought I'll show this. Now, hemifacial microsomia, very controversial, still controversy going on. So Miasini, the group in Italy, they keep saying that whatever you do, the asymmetry will come back. So minimize the treatment. Don't do distraction. If you're doing distraction, warn the patients, and that is their take on treatment. Not that they don't do orthodontic treatment, but they do it, but they wait for the patient to reach adulthood before they do anything major. And there is Shade, who's written a book on orthodontics in cleft and craniofacial, and his take is on that it has to be combined, orthodontist and the craniofacial surgeon, and the treatment has to be that way. And a lot of on literature from like Korea and Japan saying that you have to address the situation early on because it leads to a lot of psychological damage, and children are withdrawn if you don't treat the patients. And basically, I feel that we need to intervene when we find that it affects development. So you need to intervene at an early age just so that you get the growth to be normalized. So here the patient came with a unilateral crossbite, and you can see that there is an occlusal cant. So what you do is to open up the bite and get expansion so that the maxilla can develop normally. So that is the appliance that you give, and expansion on one side. Because he was a type 3 kind of patient, he had deviation of the mandible as well. So along with opening the bite, a lingual flange was also given so as to guide so that he would bite normally, helping him to grow. And we are still continuing the treatment. He's still in the process of this. Parry-Romberg, another not a very common syndrome that you see. It is known as hemifacial atrophy. Basically showing this just to show that because of the atrophy of the soft tissues, what you find is that the tissue becomes very, loses its elasticity, which makes it very difficult to do orthodontics. Almost, it's difficult to get to the back. And we know that for surgery, you're supposed to band the second molars, but you just won't be able to reach there because the patient is not even able to open that much. So in this patient, we actually did distraction. I had an open bite which was closed. So we basically closed the space. This is how we had, and then we know the department we are in. Dr. Iyer did a flap, and this is how he looks. I haven't seen him for some time now. There's another patient. So one way we addressed the Parry-Romberg was through distraction, and here we did orthognathic surgery. Again, you can see that on the on the left side, I was able to get, on the right side, you cannot retract the cheek to even get a photograph. So this is when we did before the surgery, before the orthognathic surgery. And this is how we finished. Just that each appointment takes a long time. It's very difficult to get these because of the loss of elasticity, just to reach, even to make sure that the oral hygiene is proper. And they also suffer because since we can't reach to the back, sometimes they have wires sticking out and stuff. So they also are very cooperative, but you can achieve good results. Just as an anecdote, this child came with a micro shear. She couldn't, that's the mouth opening that she has. I couldn't get the photograph. I had to use a mouth mirror to get the photograph. And because of the force from the lips, basically what happened was all the incisors are retroclined. So one thing that I thought that I could do was to put a lip bumper, which basically moves the lip away from the teeth. So gradually the teeth do become in the normal inclination. Now to get the impression in this itself, we had to take half impressions of the arches and then combine it together to make the model. So it's very difficult because that's all the mouth opening you have. And that just shows that there is a little bit of uprighting that happens because of this. So craniofacial orthodontics is challenging, interesting, and always you have to think outside the box, and you need to work with a good surgical team. That's all. Thank you.
Thank you so much, ma'am. Any questions?
Last one was microtia or microstomia?
Microstomia.
Well, I could see it.
Yeah, sorry. Yeah.
Thank you, ma'am. We move on to the next session. We have a panel discussion on calvarial remodeling and syndromic craniosynostosis. I invite Dr. Ramesh Sharma, plastic reconstructive surgeon, Paras Hospital, Panchkula. He'll be joining us online. I invite our esteemed panelists for the session, Dr. Pramod Subhash, Dr. Shibu Pillai, Dr. Sherry Peter, and Dr. Suhas Udayakumaran.
Good morning, everybody. I hope I'm audible.
Yes, sir, you are.
Okay, thank you so much. So, thanks for letting me participate online. I wish I could be there in person. That would have been much more enjoyable. So I must thank Pramod for giving me opportunity to moderate this important topic. You will all agree that the purpose of cranial vault remodeling in syndromic craniosynostosis is to increase the intracranial volume so that we can increase the cerebral blood flow and thereby also decrease the sequelae of increased cranial pressure, intracranial pressure. Needless to say, it also aims to correct the dysmorphology of the cranial vault, the orbit, the midface. In syndromic craniosynostosis, there is invariably constriction of the posterior fossa, which leads to possibility of increased venous hypertension and which can have its effect creating kind of type 1 theory malformation. So the rules of the non-syndromic craniosynostosis don't apply to syndromic cases. And so there is a sea change in the philosophy which has been there. It has undergone changes in the last decade or so. So I will take up all those controversial topics, and then I hope we will be able to clarify many of these issues during the course of our discussion. So can I first go to our neurosurgery colleagues, Dr. Suhas? You would agree that many of these patients might have raised intracranial pressure, and some cases could also have hydrocephalus. So if they have hydrocephalus, what should be our approach? Should we shunt them before we do anything, or the shunting could be delayed? So what's your take on that?
If the children are, when they present to us, are not very sick, I would use PCVD as my first option, and probably avoid shunt at that point of time.
Right.
And so the other, I mean, the converse is, if you have a very sick child who is not ready for a gently major procedure, not a true major procedure, then I would prefer shunt and get away. Shunt or endoscopic therapy. I mean, choices are possible.
Endoscopic procedure, you mean to say some kind of strip craniectomy could be done so that?
No, I meant, yeah, I think, yeah, that's another option which you brought about. But I was talking about endoscopic third ventriculostomy for CSF personally.
Okay, all right. So but
three options.
What would be the So what would be the percentage of cases who would have a scenario like this? Not many, I believe so.
Cruisins invariably, to a large extent, have it.
Yeah.
And Pfeiffer have it. I mean, we know hydrocephalus is much common. Cruisins, Pfeiffer, and blood shell is nearly 100%. Whereas Appert's will go down the line, standing around 40%.
So another question which is generally asked is, how early should we intervene? Like in non-syndromic cases, you could wait till the child is about 1 year of age. And there also some people don't operate at 1 year. They might say that we will operate later than that so that the bony stock is better. But in syndromic cases, I think that logic doesn't apply. These patients will have many features which will, force us to do early intervention. So if we have to do some early intervention, how early will it be?
No, if the children are sick, timing will be a non-issue.
Yes.
So if they're sick and believing that there's a functional damage ongoing, I would try to balance the functional gains doing it early versus stability, of course.
Right. So, Dr. Pramod, I know in your center you are very fond of doing posterior cranial decompression first. So, has it become a standard practice that in all these cases who are having syndromic craniosynostosis, you will do the posterior vault handling first and then go on to the anterior vault reconstruction?
So it's a combined decision based on functional. More often than it is functional than an aesthetic. Of course, we do PCVD for aesthetic reasons also. but that number is very less. As Suhas said, it depends upon the raised ICP. And for a child with raised ICP, PCVD is our first procedure of choice. Because it reduces, we also look at the scan, the CT scan and the MRI. If there is posterior fossa compression, constriction, Suhas looks at CSF outflow abnormalities, outflow obstructions, and any presence of Chiari, then cerebellar herniation. And if these are there, definitely it's a case for PCVD.
So can I ask our neurosurgeon, Dr. Shibu, is there any role of doing any prophylactic PCVD? Like even if there are no telltale signs that the child is likely to have that, but can we do a preemptive PCVD?
I don't know. I've never done that specifically, but one thing in the situation of hydrocephalus with when you have a bilateral lambdoid with sagittal synostosis, what we have seen is if you, even without PCVD, if you just reconstruct the posterior vault, the hydrocephalus need not directly be dealt with. So without a PCVD, just dealing with the synostosis that itself most often in our experience deals with treats the hydrocephalus also. So I've never had to do a PCVD prophylactically. I don't know if has done that.
No, I just pose a theoretical question, because this could also be an argument.
It could be a situation where you're doing it as a treatment for, say, if there's syringomyelia because of the Chiari and those kind of situations. But I don't know. I've never come across such a situation.
Right. So
usually PCVD, the upwards patients usually don't get PCVD. Because the lambdoids are usually preserved, is it not? And they usually don't go for posterior calvareal distraction. It's more often cruisons and the other that need PCVD.
Yeah, upwards, I mean, one exception would be an upward with the extreme brachycephaly and turricephaly. Yeah, which we, aesthetic too, There I'm not.
So like in a given case of say Apert or Cruzen, if you have decided to do PCVD, has it to be a distraction or placement of the spring after doing an osteotomy could also be a relatively less easy operation, less difficult operation, I mean to say. Like you do an osteotomy and then just place a spring. So many centers are doing like that.
Dr. Ramesh, can I take the question?
Yeah, sure, Dr. Shen.
If your quantum of movement of the posterior movement is much larger, it might be better that you try to do a distraction than physically take it back and then plate it. Because the thing is, when you're patient is going to lie on the back, because if you expand it posteriorly quite a large amount, putting the flap back and trying to close it will also become a little difficult, especially when the patient is lying on the back. So when the quantum is large, it's probably better to do distraction.
So even in relation to springs that you mentioned, see there are different types of springs available. What we use and we call springs are orthodontic wires, night-eye stainless steel night-eye wires. But there are springs specific for PCVD and other calvareal distractions, because there are centers like Dr. Matheson's center in Belgium, right? And and gosh, they exclusively use springs. Distractors are more predictable in their outcome, and distractor you will get bodily movement of the entire flap, the bone flap. Whereas springs, if you see Matheson's unit, they keep a pivot point at the top of the calvarium at the vault and then open up only the lower part so that you get more space at the base of the posterior calvarium. So there are different ways of doing it. The reason why we use springs is because the patients cannot afford distractors. One, distractor may not be available at that point in time, and the child has to be taken up. And two, it reduces the entire time of the procedure. You don't necessarily immediately have to go and take it out. You can leave it there for a longer period till we go in for the next procedure.
Yeah.
So it's mostly, for us, it is a financial aspect that plays.
And plus, I think in the
Can I-
post-operative
can I have
period,
one more
managing the
comment?
patient is
The-
also easier.
Dr. Sherry wants to say something.
Yeah.
The
okay.
springs which we use are orthodontic wires. Well, there's one problem for that. It does not have the actual rigidity, especially when the patient is lying on their back. So it tends to kick back a little bit because the real commercial ones are slightly more thicker ones, 0.32 gauge wires, which gives you more rigidity when the patient is actually lying on their back. These wires are slightly more weaker.
Yeah,
So after expansion, it might kick back a little bit when they lie on their back.
Yeah, and moreover, if you want more movement, like the posterior distractors come with 20 millimeters where you can move it back. Whereas the springs will give you, the orthodontic wires will give you about 1 centimeter, 1 to 1.2 centimeter. So the quantum of movement you can achieve is more with distractors.
And the distractors don't kick back unless you turn it in the reverse direction. It stays where it is supposed to be unless the screws are loose. Or...
All right. Another point is that in a patient where we have done the posterior wall distraction, what are the chances that if the deformity is not very severe, what are the chances that you may altogether avoid doing a fronto-orbital advancement at a later date? Or invariably everybody will need it?
Yeah, we have a protocol of using FOR directly for older children, believing that they compensated their brain growth. And so for more than 2 years, in spite of having a gentle Chiari, we have played down with FOR directly and kept PCVD as an adjunct option for probably a later age or a different scenario.
Right. Now, suppose we have a child who comes to us early enough, let us say at the age of about 3 months or so. And so will you be tempted to do PCVD in the beginning and then later on at the age of say about 1 year or so or 1.5 years, go ahead and do the fronto-orbital advancement? Because by that time, the bones would have solidified. You would have also gained the increased intracranial volume, which definitely is more when we do PCVD. Because the growth potential in the posterior fossa bones is more than the anterior cranial fossa bones.
Sir, it depends on the need. See, if it's a syndromic case along with the midface, we look at what the condition of the midface is. Our protocol, we treat the midface also early if the child has ocular issues or airway issues. So if we do the PCVD upfront, like at 3 months or with consolidation, and we anyway have to go and remove the distractor, which is say at 6 months of age or 8 months of age, and then the child is going to undergo another procedure. And our protocol is that when we do the distractor removal, we do another procedure which might be a FOR or mid-face or a combined frontal and mid-face at the time of the distractor removal. We don't wait. And the way it works in at least my hands, I rather have the bones soft and more moldable, pliable than have more rigid bones, the way we operate. So we operate early to get the best benefit.
So Dr. Pramod, so when you say early for mid-face, how early is that?
The earliest we have done is at 5 months.
5 months. So, right.
It is entirely based on the need. It's not because the child is there, the presence at 5 months. If the child has ocular globe subluxations, severe obstructive sleep apnea, then we go ahead irrespective of the age.
So that you would be doing through transmaxillary, placement of K-wire or something like that.
Yes, transzygomatic pins, correct.
Yeah, transzygomatic. So, Correct. But in majority of the patients who don't have very severe exorbitism leading to subluxation, you agree that many of these cases could be managed just by PCVD and then subsequently taking a call as things happen.
Of course.
I'll just take it up. I believe that PCBD would do the job for ICP, but I mean, we all agree that a local pressure is a phenomenon. So when you have an extreme brachycephaly or a cruising with a frontal compression, so we do believe that additional FOR at a very early
will have to be done. Will have to be done at a later date. Yes, absolutely.
So we had FOR very early in life.
So there's one point that Dr. Gosla wants to maybe ask a question from the audience.
Yes, you can. You can.
Morning, Ramesh. It's been a long time.
Yeah.
Yes. Just wondering, is it suggestible, suppose there is a very severe increase in ICP in a situation like in Apert syndrome, where there is already a lot of honeycombing of the cranium happening or the thumb impressions happening. Yeah. Is it suggestible to do the posterior calvarial distraction and also an FR simultaneously without any airway issues?
Without any airways issues. I think if there is so much of honeycombing of the bones, to have a stable reconstruct of the FOR segment will be very difficult. So I think better might be that we do PCVD and then we get some time, and then subsequently at a later date, maybe a few weeks later, you could probably go for FOR. This is what I feel.
Because if there's, the pressures are very high, we could plan to do a shunting before, reduce the pressures a bit, and then do a PCVD along with FR, because it's simultaneous procedures can be performed. It could reduce the burden on the child.
It could, yes. That's another way of looking at it. But my only issue was that if there is so much of honeycombing of the bone, fenestration of the bones, you may not be able to stabilize that construct very effectively. We can have use of, say, Dr. Sherry. What do you think?
Yeah, personally, what I would look at is if you're looking at a posterior crowding and a raised ICP, and there will be some kind of compensation which happens. So if it is when the compensation happens in the opposite direction where the problem is, it's always how the compensation happens. So if it is during the stage where the compensation is still continuing, you have the option of actually releasing the pressure and allowing the compensation to fall back. In certain cases, it doesn't happen predictably, but I think what we are trying to do is to get the pressures down. So the compensation falls back to a certain extent and then go back. If the compensation has fallen back, that means the deformity has now become slightly lesser. You deal with that. If the deformity is very, very less, you may not want to deal with it. But if the pressures are still high, the deformity is still there, then you'll have to take a choice whether you want to deal with it at that time or not. So I think the idea what people are trying to do is reduce the pressure and reduce the problems in the second stage. If the problems are still there, you deal with it. If the problems are still not there, leave it, wait and see.
Right. Thank you. Yeah, thank you. Dr. Sherry.
One thing that what we have seen is generally the problems are not isolated, as in the child is likely to have the eye problems, the ICP problems, and all those things come together. So if there's a combination of such things, most often what we do is first would be a FOAR and generally expand anteriorly. At the second setting is when we go for the calvarial distraction. That's been what we have seen. So if there's a problem subsequently, then you do that's how we have approached it. And so far it's worked for us.
Right. So there is a question from the audience, Dr. Suranam Gopalan. How do you decide if you want to do craniectomy or PCVD or posterior vault expansion? Dr. Sherry, will you like to take up that?
Sorry, come again on that, please.
Yeah, so this is how do you decide if you want to do craniectomy or PCVD or posterior vault expansion?
We are pitting against posterior wall expansion versus a distraction.
Versus craniectomy.
Yes. I think that's what The
I
question
think
is,
we dealt with this before, isn't it? Because if the quantum, the problem is much more,
right.
and if you expand it quite a bit and you can't close the scalp back, that would be a situation where you prefer to do a
Can I-
PCVD.
Can I see? I know the context where he is asking. In a
Okay, Dr. Pramod.
multisutural synostosis, where there is like a cleavelateral clover leaf in a young child, where there is severe thinning of the bone. Hope you understand, like 2 months, 3-month-old child with severe cleavelateral. Then what would you do? What would you prefer at that point in time? If he's asking whether you would do morcellization or a PCVD or an expansion.
Morcellation is an option, but at the same time, the relapse rate is very high, especially the posterior calvarium. So unless you don't have the adjuncts, and the distractor available, I still would believe distractor does a better job because of the, as he said, the quantum of movement and avoidance of relapse and avoidance of other secondary issues of the skin, etc., etc. The natural advantage of PCVD.
But you would do a strip craniectomy at the same time of the involved sutures.
Yeah, that's an additional option, but believing that the distractors would remain stable and not get disturbed by the strip craniectomy added.
Yeah, because the strip craniectomy, I think, will make it the distractor fixation a bit challenging.
Exactly. So believing that this will not disturb, you can have sagittal suture and you can disturb the sagittal suture without disturbing the stability of the distractors. I'm not talking about coronal.
Right.
So, Dr. Pramod, so when can we have, so there is a question from the audience?
Yeah.
Dr. Murarka.
Morning, sir.
Good morning. Good morning.
What are the conditions where you'll prefer the anterior procedures first, then the PCVD?
When I said started off, an older child who is nearly well compensated in terms of
Age, yeah, that's
age.
fine. Yeah.
Yeah.
Where a hydrocephalus and a posterior constriction is not evident in any way, second out, that be out. And then actually the genotype affects my decision making. So if I know it's a Cruzen by phenotype, or if an added information of genotype is available, I might go gentle on the child, usually upwards. Or some other syndromic one or a multisutural one where I think an intuition or a genotype which gives me an additional feedback that this is going to be not very aggressive disease. So I would prefer keeping PCVD as an adjunct. And I know, and sometimes we have landed up with burning our hands on table that the FOIR does not give enough space, and we tried manipulating the rest of the bone too much. So sometimes the decisions have fallen back, of course.
Hello, sir. I have questions from the audience and Dr. Vaibhav. So I wanted to ask fundamental question regarding the posterior wall distraction. Is the intention of the posterior wall distraction bony distraction, or mainly we are looking at the soft tissue distraction? Because in this posterior wall distraction, where is the bone coming from? Is it coming from our bone distraction, or is it just dura forming the bone after the distraction has already been done? Because in the yesterday's video which was shown, the bone is not in actual contact to each other. So in urgent scenarios, just like how Dr. Srinivas mentioned, can we actually start off this distraction with a 1 centimeter gap if the soft tissue allows for it?
I think in infant, bone growth is not an issue. The reformation of the bone is not an issue. I personally believe that distraction in an infant helps only to avoid secondary issues of skin plus. Whereas distraction in an older child is of different concept because you want bone growth. I think two different philosophies when we use for different age groups.
So if I can add to that, we have looked at the CT scans of our PCVD patients when they come for subsequent procedures, and we have seen almost complete bone reformation in all the children. I say this because there was a comment which was made during one of the international meetings where somebody commented that posterior vault distraction is posterior vault sometimes distraction, osteogenesis, because it's not predictable. This is not like mandible where you can have predictable bone formation, whereas PCVD as bone formation is unpredictable. So they also said that in PCVD you don't need a consolidation phase, because as we expand, distract the bone back, the brain also is going along with it. You're not creating a void there. The compressed brain is getting released gently. So even if you take the distractor out, it won't, but the bone is not going to fall back because the brain is going to hold it. Right? So we we took biopsies from the callus when we went back and for the removal, and we have seen that, see, you have to remember that the days, it starts consolidating the day it is cut. It starts consolidating. So by the time you finish the distraction at maybe 1 month, you already have 1 month of callus which is slowly consolidating in various stages. We have seen various stages of consolidation of the regenerate by the time we have gone in. So the bone forms and the soft tissue also expands. Now the specific question, if in an emergent situation you can you distract 1 centimeter and leave it? You can, if the soft tissue will definitely allow.
In very young children, because in very young children, if you go back even 5 days, 10 days later, you would see the construct will be quite rigid. Because I've had distractor failures where I had to go back quickly. You see, it to re-fracture itself, you have to put a little bit of force. So they form very fast. But unlike in older children, I think it'll be different. I think you'll have to wait for some time for the consolidation to happen.
So this should allow us to do faster rate of distraction as well?
You can. There are people who have done that with rapid distraction. But the problem, I think, I don't know, I have not done histopathology on that, but I think the quality of bone might be different.
I think, let me ask a counter question. What are you gaining by rapid distraction there?
We can finish the distraction faster.
But at the same time, you are taking a risk of the skin on an infant who can get into trouble, deep trouble because of our protocol. So we are not, if we are not gaining anything in the ICP front, the faster distraction is not adding to the benefit for the child. If you have the skin in trouble, and let's say the CSF is underneath because of some leaks, there are multiple leaks possible, especially in syndromic ones, and you have a leak, you have a catastrophe in hand. The faster distraction in a rational way, that's within the present protocols are good enough. Consolidation might be compromised, but not distraction.
So Arun, the thing is, once you do the craniotomy itself, the brain immediately decompresses, and then Suhas does the additional barrel stavings and then craniectomy at a lower level, is it not? So which immediately releases the pressure. The treatment is done on table of release of pressure is done. The additional thing is, whatever you do with distraction is added. The immediate problem is taken care of. Would you agree, Suhas?
Yeah, I think immediately the child is comfortable. You can see the fontanelle, you can assess everything, and you'll see the child is comfortable. Unless of course, you have a rigid bone, like an older child who has a raised ICP and you have not handled the shape alone. Infants are no problems at all in terms of ICP. But older children, I agree that you might have a faster distraction in the beginning, a few millimeters, so that the child is safe at least.
In fact, I think when you cut, you feel that the thing just gives a signs of relief and it just kicks.
And that's why you don't see bone contact.
Yeah, that's why the reason I think you don't feel the contact.
Now.
It just kicks back a little bit. The brain, I think, takes a sign of relief.
All right. So suppose we have a child who reports to us. This will be, I think, probably Dr. Pramod. Can I ask this question because it's already 10:10? So these are our time.
5-10 minutes more, no problem.
5 minutes more. Okay. So if we have an older child and who has both mid-face issues and the other deformities, so will it be right to say that that could be the stage for a monoblock in an older child of say about 7-8 years?
Well, there are different options it depends upon what the child presents with. If at 7-8 years, if I have to operate, it would mostly be a functional issue or reappearance of functional issue. So, of course, there is a possibility that we can do a monoblock distraction, not an advancement though, or a hybrid monoblock. There are possibilities.
Right. So now, in the light of the discussion we had so far, so can we kind of have an algorithm that if we have a child of syndromic craniosynostosis who presents to us early enough, what should be our protocol?
Sir, it depends. I think Suhas is going to talk about that algorithm and how it should be.
Okay, fair enough, fair enough. So if that is going to be taken up, it's okay.
There's a
If there is any other question,
there's a question from the audience.
This question is regarding, it was mentioned that the treatment for ICP is done then and there. It is definitely a psychological or evidence based also, that as soon as we do the bone opening and it reduces the pressure. But is it really true that increasing the cranial volume is reflected in the cerebrum? And one more thing that you mentioned is we take the craniectomy as down as possible. What is that down? What is the down for you at your place, to be sure that yes, we have increased the cranial cavity volume and ICP is taken care?
So if you look at the physiology or pathology of craniosynostosis, venous stenosis is a phenomenon. So when I say I remain supratorcular, I sometimes prefer supratorcular over subtorcular. I go beyond the sinus as a part of craniectomy. I go beyond sinus, and that's for me, the both side of sinuses are completely bare. And that to me gives me two advantages. One, if there's a venous element to the ICP, it is better controlled, or this has a contribution towards it. One. The second is I don't have to try to cross the other side in a very dangerous way. That's my second advantage. Third advantage is somebody mentions the step deformity, which others get. Yes. I don't get at all, because the dura is in place as the rest of the bone moves, and probably a new bone forms, and I have a very good cosmetic aesthetic outcome in a craniectomized bone.
And secondly, sir, in Chiari malformation, this is like, it is other than craniosynostosis. The foramen magnum is enlarged, obviously crowded posterior fossa with enlarged foramen magnum. But in these cases, it is smaller. So what is your take on to deal foramen magnum at a later stage, when the age of maybe more than 5 years or something, if the Chiari is not getting resolving? Or is there an experience of you in this?
Yeah. So children who present extremely late with, we have adults 17, 16 who present with Chiari in a known craniosynostosis or untreated craniosynostosis. So at some point we have addressed the foramen magnum alone too. Because you have some emissaries extra very, very dangerously placed, and the parietal ones and parietal capots and torcula, which does not allow us to do a proper calvarial distraction. So we have gone into foramen magnum decompression and seen whether, we have had a very small experience, but a decent experience, I would say.
And sir, one more thing, you mentioned that we did shunting also depending upon the need. In certain cases, the question was asked about hydrocephalus or raised ICP management. So what is that need? Because usually if we do shunting in these cases, the benefit of expansion is lost. So what was that case in which for you to mention?
Yeah, I think I'm going to present that case. Thank you. You have a very sick child. You need a crisis management.
True.
There was a mention of 3 months old baby for which you still plan for a PCVD.
It was a scenario which was given.
Yes, sir. So you said you might consider doing a PCVD in that child. And put a distractor, and then when you come back to remove the distractor, then you plan for an anterior surgery, which is FOAR or a mid-face. So I was just wondering, in a child, these type of syndromic patients, they always have multiple problems. They can really fall sick. So if you're putting a distractor, and if the distractor is not being taken at the right time, the bone formation over the foot plate is quite possible. Say there is some kind of delay, a postponement of surgery for that patient.
So we do the mid-phase and the cranium at the time of distractor removal.
Yeah, I understand. So say in case you had to postpone that surgery, for a young child, we are talking about infants. So then the problem of retrieving the distractor after some time because of bone growth is going to be difficult.
Have not waited that long. We don't wait that long.
What about
even up to 4 or 5 months, you can easily take it out.
Yeah, what about COVID times? Such similar.
We had no trouble operating during COVID time. We were operating, so we could take them out.
Okay, because we had this scenario where we had placed springs, and during COVID time, they were not considered as essential surgeries.
What springs did you use?
We used the normal stainless steel
Did you use
springs.
orthodontic wires or
No, the normal,
23 gauge?
yeah, gauge wires. So we couldn't take them on the right time, and the bone had creeped in. So we had to literally drill around the entry points and then remove it.
But ideally or otherwise too in legacy, we have been using wires otherwise too. So leaving it alone might not be a bad idea unless it's poking the skin or the other way too. You keep anyway the hooks outwards, isn't it?
Yeah, that's true.
So,
that's true.
if it's not touching the skin, you might even leave it like
the problem
that.
is when you try to retrieve it with the bone formation around it.
Yeah, I'm just saying that worst comes, you can even leave it back. Whole thing can come out otherwise to connectomy.
Suhas or anybody else, have you tried using a ventricular subgaleal shunt in such emergency kind of situations? Like
No, just
you're
because
saying it's acute.
No, just because of the understanding that this is a pathology where this is going to be chronic anyway.
No, the reason I'm asking is the shunt, if we can temporize till we do the cranial wand expansion.
PCVD, etc. Maybe that's not.
If it's that urgent, maybe because the ultimate aim would be to avoid a shunt if we can.
Yeah.
So if you put a ventricular subgaleal shunt, you tide over the crisis, then you go for the next either PCVD or.
Yeah.
So that may be something we can think about. I've never tried it, but I was just. And the other scenario is now suppose you have temporarily put a VP shunt and urgently, and then can you, when you do the expansion, can you remove the shunt?
Yeah, I have to make presentation.
Oh, you are.
The algorithm has.
Okay.
Sir, I think.
Okay, Dr. Pramod. Should we call it a day now, as far as discussion is concerned?
Yes, sir, I think.
Already it's almost around 37 minutes. So.
Yes, sir.
So thank you, everybody, for this lively discussion. And I think we were able to clarify some doubts and were not going to add more confusion. Thanks a lot.
So the next two panels, we will have more on, how to sequence procedures in older children and younger children. And at the end, we will also present an algorithm, which might be useful.
Yeah, that will be great.
Yes, sir. Thank you so much, sir, for joining in. Yes.
Thank you.
Thank you, Dr. Ramesh and all the panelists for your engaging session. I request Dr. Pramod and Dr. Sherry to stay back on the dais for the next session. The next session is on rationale for surgical procedures in older children and early teens. I request Dr. Pramod Subhash to moderate the session, and I invite all the panelists, Dr. Jitendra Chaturvedi, neurosurgeon from AIMS Rishikesh, Dr. Sherry Peter, Dr. Madhupari, Dr. Dipesh Rao, and Dr. Anil Muraka.
So going forward with where we entered at the last panel. So we are going to look at now Shamrao sir yesterday discussed the older children or adults, what would you do for their mid-phase. Now this is not only mid-phase, it's why should we operate these children who are older, like more than 5 years and up to their early adolescence, early teens. So what would be the rationale for undertaking a surgical procedure in that particular subset? Suhas would be looking at even the younger children and then the reason for operating on the younger children. So we have this total of 32 children operated above 5 years of age, average age of 10 years. So when do, if I can ask, when do these, once they have operated them as very young children, for whatever reason, when do you usually see them again? Back with any kind of, not follow-up, when would you see them with issues?
I mean, we follow them up regularly.
Yes.
To see the surgical team, the ophthalmologist and the neurodevelopment. So make sure we pick up the signs of either ICP or eye symptoms or anything which is cropping up, so that we can deal with them earlier before they start creating a problem.
So at what age do they usually present? Do they stay problem-free?
Most of the non-syndromic ones.
We're talking only about syndromic here.
It depends. I mean, it can crop up anytime. I mean, there are things which have even cropped up late and even some early as well.
I guess the croussons are the most notorious.
Yes.
They are the ones who keep coming back, either with ophthalmological issues or with breathing issues. And they might have an adequate cranial volume, but they still have sleep apnea. So it can come either together, with ICP plus apnea, or apnea alone. But croussons are the most notorious. They would invariably come back, keep coming back 3 years, 7 years, sometimes later 12 years. And after skeletal maturity also, they are still not up to the mark. They still have some apnea. So, yeah.
But what's more common, Murarka sir, if you have to see these syndromic children, what's the more common reason? Is it airway related? Is it ICP related? Airway or ocular, mid-phase related, or is it ICP related? Or do they come with psychosocial problems and aesthetics issues as well?
For our experiences regarding psychosocial or reduction in performance scale, or maybe non-achievement of the developmental milestones also, like parents have present with, now you treat the IQ. Whatever you were suggesting regarding treatment of the cranial skull shape, or that is already been done, but now at this stage they present definitely with reduction in IQ.
So that's interesting. It's not only aesthetics, it's also treating IQ.
Yes, like parents come up with how this scholastic performance has to be increased now onwards. And reasons may be different. Obviously, raised ICP is one of them.
And I think the IQ is also related to the apnea. So the sleep apnea quotient of children with syndrome is kind of not well understood, because apnea can also lead to ICP and issue.
But is it possible to, for an older child who is probably 5 years plus, does your procedure have a big difference? Will it make a difference? In performance, that is.
Like
other than breathing ability, I'm talking about neurocognitive.
The surgery which was done, or you are asking like that, is there any procedure we can
surgery,
do?
Yeah, the prospective, once they present, when they say that, after 5 years of age.
No, we have to look into the cause for raised ICP only, because this is what we have to understand, is that it is not just the phenotype. It is not just the phenotype, just like a brain tumor, the most common primary is glioma. And now this genetic thing has taken over completely the surgical, not completely taken over, but it has made a major differences in survival and treatment protocol. Similarly, I believe in these craniofacial phenotypic expressions, the genotype is going to make a change, and whatever you do, the molecular studies or the molecular mechanisms may not, like there is a corpus callosal agenesis or non-development of the brain, whatever with the ICP, they are not going to increase in the IQ. So if there is a target for genetics, I think that may improve upon, but not any surgical procedure.
Has it got something to do with the daily routine also, like exercise or something like that? That adds to raised ICP, or something like somebody is doing like vigorous exercise or something like that?
Are you mentioning about contact sports? Does the child who is more involved in contact sports, multiple concussion kind of chronic concussions, do you mean?
Not contact sports, vigorous exercise.
Oh, no, I am not in
Physical, he's asking about physical.
physical activity which lead to, I'm not sure, sir, about like no personal experience regarding managing these patients with, or any history in our patients.
One thing to add upon the age of presentation and the later age of presentation, I think a child understands self-image, or he understands his self-image by 3 to 4 years. So by that time he has a understanding of how he looks. So at that point of time there's a realization, and he might be questioning his parents as to why he looks a little different from the other children. So I think that's one time when they.
So we can go through some case scenarios here, where we have reoperated on these children. So this boy presented at the age of 2 years initially, with ocular globe subluxations and severe airway issues, at which time we had done a monoblock distraction. Now, in very young children, when you do internal distractors, there's a possibility that there can be a fracture at the zygomatico-maxillary suture. As you can see in the CT on the left-hand side, with there's a disjunction there. So what happened is that the cranium and the malar region came forward, and the midface stayed almost where it is, the maxilla. So he got globe support. His intracranial volume improved, his cranium became better, but then he presented at 6 years of age with history of recurrent pneumonia, headaches, admission for lower lobe pneumonias, and iron deficiency anemia, adenoid hypertrophy. You can see that the globe has good support, cranium is okay. What would you do at this point? He is now 6 years of age. It's not an aesthetic issue.
So midface distraction.
Would you agree?
But then I would like to know, what did you do for the fracture that happened? Did you fix it?
So one way to prevent that from happening, that's a very good question. You can still use, because the Arno's unit, Eric Arno's units, they still use these 4 distractors for their pediatric monoblock distractions. And when I spoke to him previously, he had said that they also get this problem of disjunction, so they plate it before doing the LIFO 3 down fracture. This junction is plated. I think after our interaction, he went back, he saw us with the midface, the transfacial pin. So he started putting a transfacial pin which holds the midface in one piece. It's better than putting the plate. So one way to avoid the fracture is you put the transfacial pin and then use the distractor. So that transfacial pin stabilizes the entire midface. And you can use these 4 internal distractors. The only problem is 4 internal distractors cost about 10 lakhs or more for a patient.
We have faced the same problem. There was a fracture at the junction of lateral 2/3 and medial 1/3, because that part is the weaker part. So we started putting plate. Okay, and there are other causes, either are like osteotomy is not absolutely free, so that when we are distracting it, there is a resistance in that area. So we started plating, and that worked for us.
I mean, I have again one experience where we had a fracture. We put a plate, but the problem was when we were about to do the LIFO 1, I found that the fracture had not still healed after giving sufficient amount of time, because I think it's the innate problem with the bone stock of forming callus formation to get that healing area. So it was very difficult for us to plan the LIFO 1 for that child.
Yeah, so if you can keep the 3 segment in one piece, then that's the best thing.
Now, since you're also putting the transfacial pin, have you tried the pull and push, a distractor and a pull? So the distractor is pushing.
That's an option. That is an option. We'll come to that also. So agreed. Here we went ahead with a regular LIFO 3 distraction. Now, what approach would you use for this, for the osteotomy?
Facial approaches. If the cranium has had multiple procedures and you want to avoid it, you can use a subconj, intraoral, and a combination. You will get all the access to all your cuts. You can do that, or you can do the conventional bicoronal.
Yeah, so here we have not raised. See, that is one issue where we were talking about thinning of the flap yesterday. The multiple times you raise the coronal flap, it thins and then the bone resorbs, and you reposition the bone, that bone resorbs. So as much as possible, you reduce the number of times you raise the coronal, it is better, because these children invariably require multiple procedures. So if you can plan ahead and avoid the number of you use coronals, it's good. So this is done through a lateral brow incision and midline stab. So you can see the brow incision with a little bit of in the lateral brow, and then the midline stab at the root of the nose heals with minimal scar. So that's him. He was functionally better. Now look at his mandible. Have you ever had this thing that you have done the midface distraction and still they tend to have snoring, and the parents will come and say, oh, it's all okay, he sleeps well, but he still snores? Dr. Sherry?
I mean, there are a lot of cases who happen like this. When you really look at it before you do the LIFO 3, you think that you will finish with that LIFO 3 advancement. And sometimes even if after, I've had situations where I overcorrected it by 1 centimeter. And then I looked at the mandible, it looks small. But then you go back and the symptom starts kicking up. You take a radiograph and take a look at it. Just opposite to the mandible, the airway is still again constricted. So I think in such cases, I think you will have to go back.
So they inherently have a mandibular hypoplasia. Shamrao sir, you agree with that, right? They initially, can somebody give a mic to him, please? Initially, even though they look as if the mandible is prognatic, but when you get the cranium and the midface in a good position in relation to the bone, we will realize that their mandible is also deficient.
I think if you look at the first pre-op picture, any patient profile first pre-op picture, with Cruzon or Aperts, doesn't matter. You know that the calvarium is retruded, the forehead is retruded, the midface is retruded, and there is a relative mandibular prognatism, but I use the word relative because believe me, the mandible is also retruded in these patients, but looks a little more prognatic than the maxilla, because maxilla is severely retruded because of the skull base synostosis. I have changed the order of my surgery several times, where I have done mandibular distraction first, just to relieve the airway, and then done the traditional cranial synostosis followed by LIFO 3. We had a bit disagreement on this very recently, I think, and maybe I'm a little ahead of the curve, but I hope you all can prove me right or wrong.
Yes, so that's but it definitely proves that there is a mandibular issue. The way we address it might be different, but there is a definite mandibular hypoplasia which we need to be cognizant about.
Yeah, but the problem will be if you want to deal with it earlier, you will have to have some kind of some measurement, something to predict and segregate these two groups so that we can attack the mandible first. I think the only way to do that is to, when you measure the skull base in that standard, whenever we do COGS analysis, the first two values are the skull base values. We throw it out and just deal with the rest.
Wouldn't it also be on the
problem is
at the level at which
if I can
doing that on a pediatric is a difficult thing. So that I think guidelines to say how are we going to segregate this patient who needs mandibular.
If I can contribute, we have to move on, but I would say that we can look at the data of these patients who undergo midface and see what they end up with, because doing a mandible doesn't take away the need for doing a midface, right? So if we do a midface and that solves the problem, then the mandible can be kept, for a later date. Now we will.
Because otherwise we'll be distracting.
Based on the level at which the airway is obstructed.
Yes. Yes.
Without that airway analysis.
But do we
So we
have
will
an
move on.
analysis
We will move
fit
on.
for pediatric?
Airway analysis.
Airway.
You have computational.
Yeah, computational data is there
For pediatrics?
So let's move on and see another child who has undergone the same. This child, Antley-Bixler syndrome, had his anterior to third calveolal remodeling elsewhere with an attempt at a midphase also, but had significant airway obstruction. Came to us. We performed the midface distraction at 1.5 years of age, and you can see how his face is improved. His globe has support. We did not address his cranium because it was already addressed, and he improved significantly. Now he is 9 years. He had a FOR at 1.5 years, midface distraction at 2.5 years, PCVD also, and adenoidectomy at 9 years of age. Now he has a sleep study report which says his AHI is 8.3. Breathing difficulty, recurrent respiratory tract infections, disturbed sleep, and he has 70% vision loss, gone, especially during the COVID time. Then they were not going for the ophthalmologic evaluation. Only when the parents realized that he started falling down, stumbling on things and falling down, they took him back to the ophthalmologist, and by that time his 70% vision is lost. Now the question is, what would you do? What is the reason for his vision loss here? We are looking at various reasons the children present with. Suhas, do you?
No, putting it simply, probably the ICP was the highest priority. And, the second possibility is any it's a skull-based deformity, basically, isn't it? Let's say cruiser and all many of them. So optic foramen is one more thing which we are thinking, but there's no literature to support that idea.
So let us see his scan here. So raised ICP is the most plausible reason, is it not? Wouldn't you agree? Raised ICP. Let's see the scan again once more. So he has breathing issues and vision loss. Would you address them together? Do something immediately for his breathing problems? Anybody? Sorry? One thing that you can look at this when these children come is the adenoids there. So if you do an adenoidectomy at this stage, the breathing immediately improves so that you have time to think. You get a spacer and you can plan your next procedure. Suhas, would you consider doing the anterior part of the cranium looks very compressed, is it not? Does it?
I think, should be done.
Would you consider doing a anterior cranium again?
Yeah, for his sake. I mean, he's 9-year-old, so he needs some kind of it.
Because we have already done a PCVD for him.
Yeah, but I think
so the next option would be yes.
Why not a monoblock, sir?
You could.
Because that's going to address the midphase also, because there's still some retrusion there.
Yeah.
And that will support the eyeball.
So now we have done adenoidectomy. So his midface is okay, right? So if you take that adenoid mentally, if you can take the adenoids away from that, then his airway is not that bad.
Yeah, but in the future he'll still, I think.
So if we do a midphase now, then he will need a midphase again.
What's the age right
He is 9 years.
So I think.
You would, of course. I mean, we can.
Because
plan
8 years
anyways.
is,
9 years.
facial growth.
So if you see him, currently he is like that. That's his face. And the dentition. You would want to do a monoblock. Okay, good. So, but definitely cranium.
Vision loss, like better to do a ophthalmoscopy and the fundus findings. Like if
it's
there is
done.
a secondary optic atrophy, then you have to look for the raised ICP. If it is a primary optic atrophy, like sir was telling, sir, you have to see the optic foraminal diameter, is there any stenosis? So in this type of cases, if you release the optic foraminal, vision may improve. Or we can see the retinal fiber diameter, that it is like a reversible or irreversible. That also we can do with the OTC or something.
They have, of course, what you said is how it should be.
Yeah.
In this particular case, they have done all that. They have gone to LB Prasad, I guess, and got everything done and said that it's reversible.
Irreversible.
Irreversible.
Oh.
Yeah, because sir, if there is primary optic atrophy and there is like optic foramen stenosis, 9 years of age, the sinuses are well developed, so even endoscopically you can do an optic nerve sheath fenestration. It will be a very good option for this patient, absolutely. So secondary or primary optic atrophy is important. Secondary optic atrophy is secondary to the raised ICP, while the primary optic atrophy is the optic nerve itself. That's what.
In IH cases, like this type of cases are like a pseudo IH type, where we do primary optic nerve fenestration. So that is also an option.
Yes.
Dr. Subhash, it has been conveyed, like it has been done. So what next?
I'm just
No, it's an option to be considered, not in this case, which we need to
because
be.
70%, 30% still present. If you not address, if it is a progressive,
You would go for endoscopic optic nerve.
No, that is also
fenestration.
option we can discuss, and then.
Yeah, we should consider it, that we should think about whether it is a primary, when you say about 70% loss, we should think about it.
And the raised ICP
and rule out.
Slow vision loss, but if it causes, it is mostly reversible. That is the problem.
So it's we need to rule out, in at least in the mind, and by an ophthalmology consultation. That's very good point, well taken. So moving on.
What was ultimately done in that case?
Oh, he's undergone adenoidectomy. We are planning for him. Probably monoblock distraction, maybe. See, the thing is, when we have already raised his coronal flap once, and it's going to be the second time. We have done mid-phase once, and redo procedures are always more difficult than primary procedures. So you have to make your decisions very carefully. At least if you can avoid if I can avoid another Lefort 3 and probably get away with a Lefort 1 when he becomes an adult, that would be the best case scenario, right? So if I can prolong the Lefort 3 for maybe another 2-3 years, then that Lefort 3 would be more definitive than doing it at 9. This is what I would think,
His mandible is already really back. So
he will need his mandible is very hypoplastic. But then if you look at his airway in the retrolingual region, it is not very bad.
It's not too bad, but the mandible is really retruded.
Yeah, mandible is retruded. So airway is not bad.
Something about it.
Yeah. So yes.
I think invasive ICP monitoring would be a good idea, so that get should know
Can you?
the treatment can.
So you're just repeating for others that you're saying that invasive ICP monitoring is helpful to find out the cause of vision loss. So one is to consider optic nerve atrophy, fundus findings, and also invasive ICP monitoring. Two things which we can to find out the raised ICP. Yes, sir.
The other thing is very often we talk about the present, as in today's X-ray shows the mandible and the airway is good. As the child grows, you will find that the retruded mandible will again cause an OSA.
Yes.
So you have to anticipate that you will end up with a maxillomandibular advancement at a later date.
Yes, sir. Of course, all these children are kept on follow-up and the problem should be addressed as they present or even to avoid problems as well. So I have few more interesting scenarios. This is a 9-year-old. Upwards previous surgeries, she came initially with breathing issues, and again adenoidectomy was, and that's her. Sorry, obstruction. So adenoidectomy was done. She was okay for some time, but again, came back with after 6 months. Again, came back with breathing issues. Not very well preserved neurocognitively. She is not very bright. The mother is a single mother, concerned. What would you do? The problem is primarily airway related. Dr. Madhubari, would you do a monoblock in this? And
I think I would go for.
And I hope you can see on the 3D, there is a small void on the left, just above the left supraorbital region, where you can feel the pulsating brain. The scalp is very thin.
Tricky. I think somebody else has to take this. I'm still thinking.
Can we have a look on the MRI posterior fossa? Breathing difficulties, breathing spells, and is it?
It's not bad. I don't have the data.
No problem. But is it normal? Again, invasive ICP is to be done. I would go for ICP monitoring.
So you're looking at the neurological, right? Okay.
Because lower cranial nerve sometimes recurrent URTI, subtle micro aspirations and breathing difficulties, irregular forehead with thinning and veins. So I would go for, I would suspect raised ICP.
I think I would go for a PCVD for this patient.
And why not the mid phase?
Because I think the rest of the relation seems to be fine for this patient. And I think that tonsillectomy has taken care of. It's probably the increased venous pressures indirectly causing airway obstruction.
I guess this is going to be very tricky because there is some cerebro-cranial disproportionate. The forehead is not so good.
Yeah.
As much as the posterior fossa can get addressed with a PCVD, the fact that the forehead is not good requires attention, and there is sleep apnea because of the mid-face retrusion, if that is the case.
So would you consider the fact that she improved with the adenotonsillectomy?
Yes.
But then went back again, would mean that if you actually improve the airway, she will do better?
Possibly.
Yeah.
Yeah, I think we have a sleep problem.
Yes.
Okay, so the airway is not good.
Yes.
I would check the adenoid region again, see whether that region is okay and acceptable, whether there is some tissue remaining. So one by one, is the sleep problem airway because of the raised ICP? So check the raised ICP, make sure, because the calvarium doesn't look terribly great. So is there a space problem there, which is leading to the sleep issue? If it is there, then we need to
the brain that you can feel, I don't know if it is useful or makes sense, in the void is not very tight.
Right.
It's like external. Yes, sir.
Sleep study, AHI 12.7. That's the severe category. Yeah. Okay. And I'll be more intent to do mid-phase advancement.
Okay. So mid-phase.
See, that may cause raised ICP also because of the.
So that whatever the airway contributing to the ICP will reduce when you do the mid-phase.
That's the main reason, breathing difficulty and other things. So that may help in reducing, if at all, the ICP is raised.
Right. So Deepesh, would you consider doing the cranium at the same time?
I was thinking about that, but because of the way the forehead is and the amount of reconstruction that it will require, I'm not sure if I can use the same bones to reconstruct. If I'm able to reconstruct with the same bones, then we can do a monoblock. But if you're going to use bones from the parietal area,
because it's completely deformed.
Yes, exactly. So with that in mind, it has to be staged.
Yes. So if you have to put a distractor, what device would you use in this? for mid face.
An external, because
An external.
because the way the maxilla is, the mid face is, it is tilting upwards. You need a multi-vector so as to make sure, and that is also contributing to the apnea, because it's the
Yes.
so to make sure that it can get that clockwise rotation.
The fact that you have to use the red would preclude the cranial procedure, because then it would be difficult to fix your external device.
So use the red, finish the mid face, and then when you're going back, you can do
Okay,
the
good.
cannulation.
So let's move on. 11-year-old female, Cruzon, 2 times cranium addressed already outside. Now presents no sleep apnea, recurrent, though she has recurrent in upper respiratory tract infections. Vision is normal, no exposure keratitis. Incomplete eye closure, proptosis, reduced glow support, mid-phase hypoplasia, malocclusion. This is how the child presents. She is well preserved. She is first in her class in school. Probably Suhas, would you think that the initial 2, whatever craniotomies was done, even though there is no advancement which has been performed, that has helped just decompress the brain twice, and that has preserved her apart from the phenotype?
Yes, possible. I mean, sometimes just release helps, isn't it? Especially in infants.
Yes. So now the presentation is that she feels she is not normal in school, and that, and she's 11 to 12, and it's a psychosocial issue. Now the parents are concerned. She has no functional issues per se, but the parents are concerned that her child will probably, go worse from there, and they have brought the child. What would you do?
She has no eye problem.
No.
No exposure keratitis.
No. Even though there's so much of proptosis, there is no.
Yeah, if I can delay, ultimately she'll need Liford 3-level advancement, but if I can delay, it will be better.
So I guess again, this is a situation wherein you have to weigh everything, whether the child is doing well in school. She is doing well in school. So although there might be some issues of stigma from the Cruzon, she's academically doing well. Parents are not very happy because she does not look like her peers and friends.
She's not happy.
She's also not happy, but academically she's doing well. So if we can first step would be to try and get her some psychosocial support from a psychologist, a clinical psychologist. Yet if she's refractory to that support, then yes, a surgery can be indicated early, because we all know that if we delay the surgery, it is that much more predictable, that much more stable. But if we can't, because after a clinical psychologist's intervention, then intervening early would still be the right option.
I completely agree here, because not just the raised ICP, but the focal hypoperfusion at the site of the cranial, tackling the cranium and expanding it definitely improves functions. She may not gain much in the IQ, but definitely some functional improvement should come. There are evidences like reports and literature supports this.
So you would say that earlier is the better?
Earlier, yes, definitely.
Earlier is better. Okay. Dr. Sherry?
She's academically quite good. Interacting with people, I would still wait for the mandible to complete growth and bring it in, so that we can reduce the number of procedures.
The mandible to complete growth, you said?
Yeah, so that then it becomes, same thing as what Deepesh said, because then it becomes more predictable and the number of procedures can be brought by. In a girl, maybe after 14, 15.
15. So would you consider the impact, psychosocial impact that she will have on her psyche? Are you okay with that?
She's just 13. That I think that's what Deepesh was saying, that trying to bridge that gap by the psychological evaluation and counseling. If it doesn't, then no way, get in. But I would overcorrect in such cases.
It's very difficult. So I guess as much as she's academically bright, so which means she's doing the right things in school. She's comprehending. Yes, she is getting peer pressure, but
good.
if we don't have a clinical psychologist work on her at the first instance, then we will set,
So the question, moving on, if you have to operate, let's say that we have to, what would be your procedure? Murarka sir, you said mid-phase.
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 But with overcorrection.
Mid-phase with overcorrection.
Why would you overcorrect?
Because the mandible is not completed its growth.
So if, okay, fine. Again, mid-phase. Would any of you do monoblock in this?
If you see the lateral, I mean, the supraorbital rim looks bad.
Deficient.
Yeah.
So would you do a monoblock on this?
If we can delay the procedure for a bit more years, like 3 more years,
Her
then
scalp has been
monoblock.
raised twice already.
I won't do it.
You won't do it. Nobody would do it. Sorry. We did a monoblock distraction, got it forward. Because see, my concept is that if the upper lid is behind, you do the mid-phase, she would still look proptotic. Because this is now a aesthetic procedure. Of course, with functional benefit, but the primary reason why we do is for aesthetics. So then we should try to address it as much as possible. So here you can see that overcorrected, okay? Because there will always be relapse. There will always be relapse. So it is a monoblock distraction of the cranium and the midface that has been performed.
Sir, may I ask one more question? So we are operating because there is pressure, social pressure. The red frame is the most, like, I think it breaks the patient down into bits and pieces. Every time anybody gets into the red frame, for the duration of the red frame, the child is going through literally, I guess, hell, if that's the word to use. Also, during the period when they're overcorrected, they don't look normal again because they don't look, because you have to overcorrect. The midface is now projecting slightly more. So what happens in that interim period? You've had a distractor, you've had the overcorrection, so that 2 or 3 years are anyway kind of.
See, it's an apparent overcorrection. I mean, it's a relative overcorrection in relation to the mandible. But if you see, her mandible is already hypoplastic. And if you can look at the, I think this is about 6 months post-op. You look at the relation of the, at least in the profile below, you look at the relation of the globe to the forehead, it is better, right? So by the time she's 16 or 15, we can do some lateral filling up augmentation with fat procedures and it would be reasonably good. And of course, she will need orthodontics. And it is likely that she may need a bijaw procedure at 15, but then it's at a lower level. We have taken away the need for a cranial procedure. We have taken away the need for a LIFO 3 level procedure. Probably on the top, you're thinking about just augmentation, filler augmentations. And regarding the, yes.
I think it was a child's decision that something has to be done with her face, isn't it?
Desire.
Desire, yes. I mean, so once she understands, and I think as a surgeon, we are thinking from her perspective, I mean, with our perspective in the mind that she's going to have a big frame. But if the child is able to understand that this is going to be the procedure, the decision lies in her head.
Coming to that. Now, again, in this particular scenario, if she is class 2, small mandible, if she says that my small mandible is fine, she wouldn't get operated at all.
Yeah.
You know, so she'll be just a class 2 mandible. Last, we'll just run through this because we are out of time. Again, similar presentation. Now she is on CPAP. She is on CPAP. She cannot sleep without a CPAP for the last 5 years. Single father, she doesn't have mother. And this is her scan. This is her midface. Ophthalmology, discus edematous margins are blunted. And that's her airway. And the reason why she was, because there was no reason why she should be on CPAP, is it not? They can have obstructive sleep apnea, but to be on CPAP or a BiPAP was, so then we looked at the scan, we saw that there is posterior canal atresia. Okay. Now, what would you do? Quickly. We will address the midface, of course. Yes, no, no. Only the.
How old is she?
She is. How old was she? She was again 11, 12. Yes. So I'll tell you, we have to finish this. So again, hybrid frontofacial correction, because the amount of, I did a frontoorbital advancement, but not a distraction, because the quantum of advancement required with the cranium was not that much. So advanced and fixed, and then along with that, LiFO3, and Dipesh, you were talking about the stigma of having that thing on the head for a long time. So you can use the push-pull technique, where you have an internal Marshak, as you see on the lateral cephalogram there. There's an internal Marshak and an external red, and it goes together. So you pull with the red and push with the Marshak, the midface, and then at the end of distraction, you can remove the red and take out the ports of the Marshak, and the Marshak stays inside internal during consolidation for 3 to 6 months. So the stigma is there only during the time of distraction. And the reason why we could do this procedure, if we look at the apport that we saw with severe cranial deformity, right, where you will not be able to fix the distractor, that then you cannot do simultaneous monoblock, either hybrid monoblock or monoblock. But when you can safely advance and fix the cranium, or do you can fix the red frame, you can consider monoblock. That is when you differentiate between a monoblock and only a midface. Any comments?
No, but how do you retain the monoblock segment when you take out the red?
So the cranium is already fixed.
Yep.
Cranium is fixed at the time. It's an advancement. It's an FOR.
Ah, right. Okay.
It's an FOR done.
Okay, FOR. Okay.
That's why it's hybrid monoblock, because the
so it's
cranial
the
advancement
midface
is,
which is being push-pulled.
Yes.
Yeah, fair enough. Midface by FAR, yeah, it's combined. Yeah.
Does this hybrid mechanism hasten also the distraction?
No.
No, it doesn't. It's only for the consolidations.
Yeah, so you see, you don't have to distract the cranium always, right? We do FORs in adults. So it's easier. See, this having two segments to distract, two which are separate, it's easier if you have one segment. And the cranium is more predictable when you do all the, it's like a proper FOR. You completely finish the cranium.
Where do you fix the FOR segment? Because now, especially in the orbital
You'll have to
level,
fix the back.
Let's assume at the orbital level, because you have the construct of your FOR, you've advanced it and kept it forward. Now you have a moving element down at the LiFO3 level. So
laterally.
So it's a bandeau, right? Routine bandeau. I don't have intraoperative picture. It's a routine bandeau with the frontal flap, which is advanced and plated at the tongue and groove, and also we put a plate posteriorly to prevent the. And in these adult or older children, we can use titanium. You don't necessarily have to. And that's her again. She will need some fat fillers in the temporal region because of the multiple times the temporalis has been raised and the temporal hollowing. Well, she will need most probably a settling osteotomy later. But thank you. Thanks. We will have a very small tea break. How late are we running? We're running 15 minutes late. So we will have a 15-minute tea break and come back. And then Suhas will go with the algorithm and try to sum up, the sequencing in very young children also.
Thank you, Dr. Pramod, and all the panelists.
It's not something that you do unless it looks too brachy. But we have burnt our hands. I was just mulling over what made you feel that we were not coming into the roads together. Because yesterday you mentioned that we were not coming to the roads together. You said a point and I said a point that for a neighbor that you were PCVD and he said that you reserved for the PCVD for APOD children. Yeah, generally, see, let's say you want 1.5 centimeters anterior advancement with the FOR, and that looks reasonable for that particular port. So then I must take
Don't you think that the APOD children are significantly
yeah,
most
exactly.
Yeah. And in fact, their posterior functioning is actually
Not due to lambdoid.
Not due to lambdoid.
It is brachycephalic. Yeah.
And yet their posterior functioning is much more than the crusenture.
Appearing because of the coronal involvement, yeah.
Yes, of course.
Because the cruzen is a pansynostosis. True. This is a coronal involvement.
Yes. Yeah. But the way
it's not a rigid thought.
Yes.
I do play with
I
it.
think that in most literature, when you see the scatter of which patients have received
PCVD.
APOD features in their first.
Yeah, but at the same time, when a bird presents to you first time, he or she does not have a raised ICP.
Correct.
Yeah,
Yes.
so that's why I use a
They have large functionals.
Exactly.
The
So
gaps in their head, their anterior and the posterior functionals are so wide that by the time they fuse, they're not developed.
Exactly.
Because you keep feeling it's
So
not
that-
tense,
yeah,
it's tender,
yeah,
it's
yeah.
no problem.
Yeah.
They're functioning well.
So I think an additional element unnecessarily at that moment, functionally.
No, so we don't do it earlier. So we do it
After the
around 10 months to 1
and
year.
what I FOR?
15 months.
No, so my problem is like this. You are talking about ICP, I'm talking about local pressure. A regional involvement of frontal lobes, bifrontal. Because of the bicoronal involvement, it's completely compressed. There's a regional increase in pressure like any brachycephaly. So they'll have all this language.
Posterior also tight.
No. This is not right. There's a coronal involvement, so it's essentially brachycephalic, but the frontal bone is more involved than the posterior calcareum. So global rates of pressure is not there. Global rates of pressure is not there, but there's a regional discrepancy. So that has to be addressed because the child has to develop. Because it's bifrontal. Children and adults or anybody is devastating.
Yes.
Because both frontals are completely out of their function. So it's not a ICP business at that moment, at the present. But you can do it because for aesthetic reasons, I always see that the FOR does not serve the purpose.
It does not
aesthetically.
Yes, and also it does not. Do you think always that, especially in bicoronal cases, because of the discrepancy being so much, when you get the posterior and the anterior done properly, without having change sequence,
They look better.
They look better.
Of course.
They function also better.
Functional, I'm not sure because if ICP was never an element, but I've seen brachycephalics are always brachycephalic if you do only FOR.
Yes.
Isn't it?
Yes.
So PCVD has a role in them, especially.
There are these non-syndromic bicoronal. In fact, there now literature evidence where non-syndromic bicoronals, although they are non-syndromic right now, I think we've not yet found a syndrome because there is always something that is linked to. Just by PCVD, their forehead shape also improves.
Yeah, because there's a compensation happening.
Yes.
It's always like that. Not dramatically. Children who have some kind of a raised ICP, the forehead is much more disturbed.
True.
So doing an FOR, PCVD preceding FOR has this as additional logic.
Yes, exactly.
Upwards, Yes, and most of the time, the problem with this delaying, no, the more you delay, if you have a bicameral synostosis, the skull will climb upwards. So turocephaly will become more, less manageable with only a forearm.
That's what I was saying.
Exactly.
The method of remodeling makes a difference. See, for instance, if you are remodeling frontal and the orbital band, the way I remodel is use a parietal for the forehead. So
I think I agree with you.
So what happens is you actually address the calvarium.
2/3 at least.
2/3
at least.
Yeah. So you remodel the entire calvarium, allowing the turocephaly to be addressed, forehead to be addressed, and the problem with these forearms, especially because the forehead, the frontal bone is so flat. However, geometry is like just arranging it.
We will not have a nice curve.
If required, can I borrow your this adapter?
Yeah.
I forgot to. I forgot to bring this. That's what I'm. Yeah, but I have that. This thing is there. Oh.
First,
Morning. Can you hear me? Morning. Can you hear me? Morning. Can you hear me? Hi, organizers. Can you hear me? Hello? Hello?
Switch it clear.
Hello, organizers. Can you hear me?
In the sleep. In the sleep.
Hi, Suhas. Can you hear me? Suhas, can you hear me?
Kindly be seated. We begin with the next session on ICP or Orbit Airway Functional Outcome and Base Sequencing of Procedures by Dr. Suhas Udayakumaran. I invite our panelists, Dr. Krishna Sharma Rao, Dr. Pramod Subhash, Dr. Anil Muraka, Dr. Jitendra Chaturvedi, and Dr. Jagjeevan Jagdishan, who will be joining us online.
Thank you.
Is everybody around? Dr. Jag has joined online.
So I have joined here.
Online. Good morning, friends. Has he joined? I have one more panelist from. Yeah, so he has joined. Dr. Jag, hi.
So I can hear you. Thank you.
Yeah. Thanks, Jag, for joining and taking the trouble of. We appreciate your joining again. Thanks a lot.
Thank you so much.
Yeah. So, essentially, this panel discussion is to bring about all the thoughts which we have been collecting over last, let's say, 1+ days, including how do we make a decision at any checked scenario. So, we are not going to look at very straightforward non-syndromic, of course, and not even probably the very straightforward decision making in the initial stages. We'll put everything together. We'll try to put everything together. Again, it cannot be tailor-made. It cannot be customized in a very strict way. Algorithm in these children is a complex one. You cannot have one single one. So we call it pragmatic, and I personally approach it in a 360 manner for the craniofacial anomalies. So you agree that the rest of the syndactyly, etc., has to be tackled in appropriate time, but that I'm not including in this this discussion. So we do need algorithm very specifically because there are lots of different presentations and lots of different surgical modalities and lots of different specialties that are involved. So bringing them together with a single voice is what we would refer to as algorithm. And after the initial evaluation, we do have some direction. Like let's say we did discuss in the morning that if you have a child with a raised ICP who has a Chiari and hydrocephalus, and with if there's an additional aesthetic involvement, PCVD is an option. And we did dwell on the fact that sometimes shunt might be necessary in a child who is very sick. in an older child, as I thought we would do, in an older child, if there's a raised ICP and aesthetic issue with no evidence of Chiari and no evidence of hydrocephalus, FOIR is an option, especially in an older child, not a first-hand situation. And in child who is probably not Cruzen's or maybe a gentler kind of variety and appearing at a different age. And the airway and ocular involvement, if it's there, the mid-face or the face needs to be addressed. The face needs, I put the word face because I had put the face MD when I had presented somewhere else, and somebody corrected me that you can have obstruction at different levels. So you need an assessment before you create a distraction plan. The other functional aspect has to be in place, but I'm not bringing it into this panel discussion. So this is not a very compartmentalized kind of algorithm, but at the same time, it has a direction, and it would stand to physiology. Although again, not a rigid direction, you can play with the directions depending on how the child presents to you. So I'll start with a very complex scenario where again, which has been, I mean, you'll see a spill of the information in the last day's presentations, etc. But this would allow us to clarify how we think. So this was a 3-month-old. Again, this child presented to us with severe failure to thrive. The child was about 3-month-old with just around short of 3 kgs and very sick, very sick with repeated infections, etc. And obvious full fontanelle and signs of raised ICP. Again, we had enough of discussion that whether you can use PCVD or shunt for this particular situation. That was a child. So scan showed a tight posterior fossa, Chiari, presence of obvious hydrocephalus, and a sick child. So I chose to do, and this was the skull. So instead of PCVD, I chose to do endoscopic third ventriculostomy. Again, the same thing which we had discussed yesterday. Failure to thrive, progressive hydrocephalus, syndromic situation. So the options we did discuss again multiple times: ETV versus shunt, PCVD. Somebody might think about FOIR and as a distinct possibility to list it off, but not to use it, of course. And a role of oscillation if you don't have a distractor or if you want to avoid shunt. So I did a ETV and I had a CSF leak at 1 month. So it's very clear that ETV is an option, but a 60% success rate only. Here I went on to do a shunt, and because the child was leaking, I had no choice. But I went on to do a foraminal decompression and a PCVD. So now, again, this has been discussed yesterday. But the third point I want to do, bring it up, like Shibu mentioned in the morning today. I have a VP shunt. I am planning a PCVD when the child is much stable. What do you do with the VP shunt? This is for the neurosurgeons. What do you want to do with the VP shunt?
Use the mic.
So other questions have been dealt with well yesterday, so I'm not dealing on them.
So you want to remove the shunt, basically. That's what you want.
If what do you want to do with it? You have a shunt in situ and you are subjecting the child to PCVD. Okay, and of course the cuts, etc. we discussed yesterday. Per se, what do you do with the shunt?
So you can give a trial of shunt clamping, and if the patient is
we are doing a PCVD anyway, so we are dealing with the function anyway.
No, I mean if you want to get rid of the shunt because you want to do PCVD, I mean, so you can give a shunt. You can tie the shunt and see if the patient is doing fine and there is no need of it, and then you can go ahead with PCVD. That is what.
Yeah.
That is one option.
Yeah. We'll complete the thought process later. Let me come. Shivu, you had this question in the morning. Tell me your thoughts.
So once you've done the
PCVD is done. Distractors in place. The shunt. I need to decide what to do with the shunt.
Yeah. So again, same thing. I would try to take out the shunt.
Yeah, I did not take out the shunt because I like it because tomorrow it might be necessary again and another scenario. Yeah.
Tie it off and then if. Yeah.
Yes. Yeah. Yeah.
If you programmable shunt, then you can play around with the shunt.
Yeah. Again, but a programmable will not give you a complete occlusion effect. But so.
I will never take out the shunt.
Yeah.
I burnt my hand twice, and I will never take out the shunt. Whatever the family, whatever people.
Yeah.
Why? I mean, for us, the
because I've taken it out.
Can you use the mic?
I fully established that the shunt was not functional. We even did radionuclide shuntogram and it was not functional. And then I removed the shunt. 2 times, same story repeated. The wound started leaking on third post-op day and I could not do it. I have to again go in and put a shunt which was supposedly not functioning. So what harm it is doing if it's just being there? That is my question. If it's not doing any harm, let it be there. If it causes some complication, if you get into any complication, then you might as well try and remove meningitis, infection not getting treated, it's getting affected. Because over a period of time, it will get obliterated itself. I would not do it. It's my personal experience because what I say that let it be there. We've dealt with the thing, but I am not brave enough to pull out a shunt.
Yeah. Moreover, this child with Cruzans or a similar kind of phenotype might require a later procedure again. You can just open it up later. You'll come to that again. So then this is a different situation after the surgery. After the PCVD, we had a situation like this. How do you want to address it? This is the question to Pramod and other maxillofacial surgeons here. You have a situation of difficult extubation and a severe airway issue. He has airway issues primarily that added to the ICP. We did it, he got better, but he's not getting extubated.
Primarily, like I said before, I tend not to extubate the patients on table at all. And we would wait till the patient, because patients with OSA component have relatively reduced respiratory compliance and recovery. So they find it harder to recover.
Multiple infections past.
Yeah. So therefore, I would be patient and extubate maybe the next day, not earlier than. Never on table extubate.
Even that was getting protracted in spite of the delay.
I would still not worry about the extubation. If it's beyond 2-3 days, I would then think of trachea rather than extubation. I would like to preserve the airway because it's extremely important. The course can be extremely difficult in the hospital, in the ICU, where the patient is paying a lot of money for the ICU stay, it's okay. Where we are doing, say, on an NGO basis, etc., keeping the patient for 10 days or 15 days in the ICU is not an easy option.
You want to comment on?
Depends on.
Yeah, we have done an early mid phase. That's why we done an early mid phase. So we did differently. We approached him with a very early mid phase, and we used a robot to do it. Maybe you should come.
This is yes.
Yeah, he was waiting for in the ICU plus and beyond. He never got extubated for some time, and he was a very sick child.
This was the child with the
mother.
Yeah.
We not tracheostomy.
The tracheal sleeve, is it? We look at this.
No sleeve issues. He never underwent a tracheostomy, so he was sick. Couldn't be extubated, and he underwent a very early mid phase, very early. You want to comment on it?
Yeah, this is after the PCVD, right? That he's the
PCVD and mid phase.
So how long did it take for the distractor to correct the airway? Because if it's an acute airway issue.
So you can start distraction. You can do distract on table itself. Yeah. If it is an acute airway, you can distract 5 millimeter to 1 centimeter to immediately correct the airway. The only point being that you will have to retain the distractor for a longer duration for consolidation, but they will consolidate because these are very young kids. They will consolidate and without much relapse. So you can on table distract.
Any role of palatal split in such young babies? Any experience with palatal split? Just to improve the airway and the back before the baby can become a bit bigger, and then you can plan a proper medication.
It does not relieve or increase the space. Instead of a full palate, you have a split palate. What difference does it make? It will not make any difference at all.
I was just asking the same thing, like nasopharyngeal airway.
Yeah, you could say that.
I was asking about trial of nasopharyngeal airway. Because it's an
Of
acute
course,
situation.
yes. So the child is intubated, and if you have to, all our patients get a nasopharyngeal airway. The type of nasopharyngeal airway, you have to be careful because, and these are small human nasopharyngeal airways, and they have more secretions because of the small mandible and, the occluded tongue-based region. So the chance of these airways getting blocked and again sudden desat in the ICU are very high. So another way to manage this is with these rush airways, which are the yellow ones, or you cut a endotracheal tube itself, use that as an nasopharyngeal airway so that you can have the connector of the endotracheal tube reattached outside, and then you can give CPAP.
Because I think very less number of people would be going for another procedure in such a sick child in the acute stage.
Two things can be done. One, you on-table distract, and then you place an endotracheal tube as an airway, put a connector, and give positive pressure.
And I think Pellerin's original article on transmaxillary pins, he just puts the pins across. He doesn't do a bone work, is it? You want to comment?
So he does. The Pellerin's original article is not a Glyphor-3 distraction. Yeah. It's a osteotomy less distraction, but then that is the title. But he cuts the skull base. It's not that there is no surgery at all. He is not putting just a pin and distracting. Yeah. He cuts the orbit or the skull base just behind the orbit. So that is why when I spoke to him in his series, he had two patients who had progressive loss of vision during the course of distraction. Which,
when he's not
because you are stretching, because you are stretching the orbital apex as well.
Yeah.
You're not, in Glyphor-3 distraction, you are distracting the orbital rim. Here he is distracting the entire orbit. And when you distract the entire orbit, you are distracting the globe also totally, which can put pressure on the nerve. When I said that, he said that could be the reason that, when he returned, reversed the distraction, the vision improved.
So I think this was a very rare situation, of course. But at the same time, can I go to slides? Switch slides.
Jag, do you have to this?
We've not had any scenario where there is an acute airway issue, but if at all, what we try to do is when we're doing the calvarial procedure, if there's an airway issue, as we mentioned, we managed with the nasopharyngeal airway initially. And if that becomes problematic, then we consider mid-phase.
But you do more of tracheostomies. Before it comes to you, the children probably get the tracheostomies up front, is it not? Is that
we aim to get the referral early on. So nowadays, as soon as the child is born, we get a referral. So the management is slightly in our control at the moment. But of course, sometimes they don't get referred early enough, so they might have a tracheostomy already when they get referred.
But tell me, do you find tracheostomy very difficult to manage at home, especially for youngest ones? Because a small human, etc., you might have sudden block occlusion, etc.
They have a good setup. Initially they stay in the hospital till they are managed appropriately, and the parents are taught how to do the tracheostomy changes. So they have a tracheostomy nurse who supervises them and monitors them, and they are given a kit with suction and everything, how to manage. And the nurses supervise them till they are safe to go home. And initially, the tracheostomy nurses do a home visit as well. They go home, visit them, make sure they're safe.
But it's that huge burden of care, is it not, on the system and the parents?
And the secondary effects of it?
Secondary effects, again, we've not seen any major issues. We aim to try and decannulate them either by...
What is the average age at which they get decannulated, these children? Once the tracheostomy goes in?
Probably around 6-7 years of age, when we can consider about consider mid-phase procedures.
Is there any way to predict these airway problems? Like we have these finite element analysis softwares. So for such major procedures, what if we can procrastinate and if we can predict that it could lead on to a airway problem, we also combine one more procedure like the one.
See, the reason why the child had such a immediate postoperative course is because of the preoperative airway problem. You don't find such an airway problem in every child. The more severe their preoperative airway distress is, the more likely that they can have a rough course.
So that's why, we understand because of an intraoperative procedure, there's going to be a swelling, there's going to be edema, and it's going to increase the already compromised airway. So if we have a correction factor and try to predict which patient will land up in this situation, don't we think that we are better prepared?
Yeah, we can look at which children had issues and what was their preoperative issues, and can say probably say that these children can have are more likely to get postoperative airway issues. Yes.
Go to slides.
Yes, sir.
The way to look at it is prioritizing if the airway is an issue preoperatively, prioritizing that over the calvarial procedure.
But this was
plan the airway first before you do the calvarial procedure. You can do simultaneously, that's okay, but plan that first.
So I think
this particular child was a complex one. You agree? His fontanelle was full. Child had a failure to thrive. So airway was probably equally contributing or contributing. So calvarium had to be addressed because the fontanelle was full. So
do both then.
Yeah, both together probably. So this is on his follow-up. He started increasing his head circumference, and that frontal bossing started appearing. So again, what next now? He had a PCVD, he had an airway tackled. Any comments on this now?
Shunt is still there.
Shunt is ligated.
Ligated.
Yeah. I can of course open it. That's easy way. What else? Yeah. So there's an element of hydrocephalus or raised ICP in some form. Airway is not contributing. The PCVD has done something, but something else is still persisting. How do you want to look at it? Anybody can. Not much actually, because but the frontal thing was bossing.
Yeah, bossing.
There's an element of ICP clearly. Sure.
We can see the hydrocephalus. We can find something to do with this.
We can open that sun tube.
Yeah, we always try to reduce the possibilities of usage of shunt. So what we did was we did a FOIR, brought the bone. I mean, it was just a staggering step, but we did a FOIR. We just modified his forehead, and then it continued. I changed it to programmable shunt, and then opened it up. So,
what pressure did you keep it for programmable shunt, sir?
We tried to keep it on the highest side, and then slowly come down if the head circumference is not maintained.
80 around 80.
No, 80 on Codman is very low. It's like any normal infant.
Normally we do medium pressure is 70 round, no, sir. So you 90, 100.
The higher side.
Okay.
So if it's a Strata, which I use for these kids, because Strata has an inbuilt anti-siphon device. Codman does not have, unless you use a siphon guard.
Okay. And sir, supposingly if you have put in a shunt and then you have done a distraction.
Yeah.
So do you see over drainage if you keep the shunt there only? I mean,
because you want.
That's why you want to tie the shunt and you want to remove the shunt.
To add to sequelae. So we try to stagger. I mean, this is the logic. May not stand the test of time because nobody understands all these things very clearly.
That's why you want to remove the shunt and to avoid over drainage.
The shunt to the last.
The ICP has been taken care by the
other
release procedures and all
then
that.
Give the shunt a place.
Okay. Okay. Sir.
And in these cases, sir, I believe that just a static or single ICP measurement, more likely a dynamic pressure reactivity. No, I'm just telling for the discussion for that we can take it forward. That cerebral compliance in these craniofacial syndromes, we should tackle now, and pressure reactivity, especially dynamic pressure reactivity, so that we understand the mechanism of why the raised ICP. There is a PCVD done and then FAO, then still a shunt is required. So I think further studies are needed to look in the PR index.
Yeah. Yeah, only thing is these children are very complex. You
It's
have
quite really complex.
too many anesthesias already happening. So the whole situation is a very traumatic one. So you want to cut down as many things as possible, and well, it's nearly well understood.
So, and anyone on the floor is aware of any studies or any literature regarding pressure reactivity index? Dr. Subhash, do you have any regarding PR index being studied in craniofacial syndromes? Less likely, I'm not very sure about it.
Not much studies, right?
No,
Like in
infants,
TBI only it is going on. Like, but here we have done a short study in Niman, sir. Like only
Intra-op, you said intra-op.
Intra-op we put, and post-op also we kept for 2 days. So there are definite after surgery there is a reduction also. But
Pre-op usage is in these infants we don't.
yeah, it's very difficult to keep that like sir interparenchymal also because they will be continuously moving, you know.
Yeah. So this is on follow-up. He had this cervical junction anomaly. Most of these children have some kind of cervical junction anomalies in some form, either block vertebrae, CV junction anomalies, or secondary to the additional procedures. The initial scan did not pick it up. The later scans had this. So probably the large head and all those procedures, and probably all the elements of his processes probably created this disjunction. So that's what he had. So for that he underwent a fixation. Again, so this should be kept in mind when you have a child with Croson, to look at least the CV junction in your CT scan. So CV junction should be evaluated always in any child with Croson. So he was not Croson, he was a 5-5 proven, and one of these days he had a sudden death because probably he had a hit on the cervical junction again. That was unfortunate. Go ahead. Yes.
I have is there any AI driven, can you predict any, is there enough data in the world or in India at least that AI driven, they can predict the outcome? Is there anything done with the artificial intelligence in this matter?
No.
With this mutation specifically, I am asking,
Yeah,
but
yeah.
when there is a genotype present, we label glioma as IDH mutant wild type. There is going to be a time of CFS is going to be labeled as genotype.
Exactly. So that's why we were talking yesterday. Having a genotype or doing genetic studies in the beginning itself can add to the whole picture. Like this particular child, you will see it in further presentations. So you have a child like this. This is a 11-month-old with extreme turocephaly and lacunar skull. Child is doing well. One of a twin, 11-month-old. What do you want to propose, panelist? Dr. Murarka?
This is similar to the question that was asked by Sharon earlier.
Yeah. Pansynostosis.
Yeah, can we see? Can I see the front part also? Yeah, the frontal bone looks a little bit better than the posterior part, so I'll go for the NTA procedures first, maybe FOAR.
Is there an MRI scan involved?
Yeah, Jack, go ahead.
This child is
There is no Chiari, by the way. There is no Chiari, by the way. Jag.
Extremely hydrocephalus.
There is no Chiari.
Hydrocephalus?
And the posterior fossa
No hydrocephalus.
will probably be narrow.
The child was doing well, reasonably well. No hydrocephalus, no Chiari. But this is the phenotype.
Posterior release, just get everything out of
Posterior
the
is what I would consider because it gives more volume.
Yeah, hi Shalendra.
Hi.
Yeah, hi. Thanks for coming.
No worries.
So that's the image. Now, what do you want to do?
It's a posterior release, and we take a panel from the vertex, and we can protect the transverse sinus and the torcilla around there with that bone panel, and release the posterior. And consider FOAR later.
So you mean PCVD in some form?
Yeah, because I mean, with the thin bone we can consider springs, but some form of posterior release will probably be the first option for us.
How old is the child?
The child is 11-month-old, doing well, has a twin, nearly comparable twin.
I think I would just do posterior release and say whatever protection you can do over the sinuses and leave it with some kind of protection.
Can you go on the slides?
When you say posterior release, are you just saying strip or morselization?
Yeah, morselization, just release everything so that the brain will push the backwards because he's pansynostotic. So only place he's going to move is backwards where you made the cut. So if you do anything else, it's probably going to fuse very quickly. So even if you leave a few flat pieces of bone, because the bone inside, all those bones will have such a massive spikes which go inside the sulci that you need to be very careful because you will get plenty of holes while just taking the bone off. So the whatever flat piece of bone, if you just put it as a jigsaw puzzle loosely, then it would help to make the child grow, the head grows, the bone becomes, the front stalk becomes better, the frontal bone thickens, and then you can have a chance of doing something or hanging something on a bone. Otherwise, the chances of the bone thickening are very less.
But you're not worried about the relapse, which with your
relapse is going to happen. So what we are doing is planning for that relapse to be stronger, so that what you do next will be a better procedure in terms of both reducing the ICP and a slightly better cosmesis as well. Because this kid with this pansynostosis is going to need at least 2 or 3 procedures without fail. That is going to happen.
Okay, so we instead move differently. We put a posterior calvareal distractor, and
but you also took away a lot of bone,
yeah.
like
we did a calvarectomy as I would do it. I do a lot of calvarectomy at the venous sinus level and put the posterior distractor in a very, very different kind of position. And beyond that, when we removed it, we did a FOR along with it. That's
you
how
could
we
see
did
the bone stock improving in the front. Means whatever
Yes.
you've done is a release at the back. Whichever way you do, you should just give them more space. And sometimes it's natural, and to reduce infection, distractors would be sometimes cause a big problem in the infection rate. So just depends on, means you've been lucky that this child was well till 11 months. We get these children at about few weeks old, and then you have to just release the back.
And how would you time, if after a PCVD, how would you time the FOR?
With clinical measurements of eyes and the ICP and whatever we see on the scan. So if you see on the scan that developing chiari or developing tightness with changes in the fundus with OCT follow-up, then as soon as they start showing signs of raised pressure, you intervene. But if they don't show any signs of raised pressure, you leave it later, say about 18 months to 2 years, to do some procedure, which will probably be the last procedure you can think of.
Is that what you would do, Jug? That's in your unit, it's the same?
As Shailendra mentioned, we get them early on and putting a distractor on them. One of the things we found difficult is the size of the screws. And when we distract them, the risk of dural tear is higher. So if they present early on, we do a calvarectomy and then take the panel from the top where there's a good bone stock and use it to fix below to protect the sinuses and wait for the bone stock to get better. During the follow-up,
frontal, forehead?
The forehead, again, the volume you're going to get from the forehead is less. So if after this release, if they form good bone and if they're still tight, we consider PCVD as a second stage and the FOAR at a later date.
When would that be?
Again, probably around 18 months or so. Before they form sinuses, definitely. But certainly around 18 months to 2 years, we can consider FOAR.
Thank you. Can you click on slides?
Small doubt, sir. I just wanted to know what type of posterior cranial osteotomy you have done. You have done a complete?
Yes. Complete with some calvarectomy.
Because there is so many lacunae there. So
no, I've done a complete. I've done a complete with some calvarectomy.
So in this, could we have considered a superiorly based clamp?
You mean a clamshell like?
Yeah, because there is still some amount of good bone there.
We have the vector which is going downwards, and then forehead anterior 2/3 we are planning anyway in the recent times. So maybe that was the reason. And you see the results are decent enough.
The results are very good. I'm surprised that where the distractor has been put, and the results you got with the FOAR are very good.
Exactly. Yeah, it's interesting. Yeah. Go to the next slides. So few more quick slides so that the crux of issues can come up again, which are missing until now. Go next slide, please. Yeah. Okay. So this is a 8-month-old with severe failure to thrive. And Apperts. You can see it's a genetic proven, genotype proven Apperts. A severe failure to thrive. 8-month-old with just around 4 kgs. Your first procedure. Severe airway issues, again, the symptoms are very classical, has severe airway issues. You can see all the signs there, the pectus and failure to thrive, and from the history. We did not go with the polysomnography, but everything was obvious. 8 months, 4 kgs. Sir?
I would address the airway, as I have said before. The airway will allow the child to thrive, and then you address the
and the procedure. And the procedure, sir.
And the procedure, I have not done mid-phase distraction at that age, so I would probably do a trachea and then continue the.
Probably that's an option. Anybody else? Jag? Anybody?
I think it depends on whether it's the ICP or the airway is causing the issues. If it's the airway, certainly that needs to be addressed first. And 8-month-old, if the airway is an issue, then we could consider a transfacial pin and distraction. If it's not an acute airway obstruction.
Yeah. So, can you slide?
He does have dilated calvarial veins, so yeah, I've always consider issue of raised ICP. If there is a tightness, then we consider posterior reduction.
But his symptoms were very classical. He used to just wake up and had repeated URTIs, etc. So symptoms and signs were obvious of the primary airway issue anyway. So we went and where the mid-phase distraction. Go ahead. Slides, change slides. Yeah, so that was the airway on CT scan. And that was a CT scan. So he underwent again mid-phase, and beyond this, he started gaining weight very well. So that's him. He's doing very well. I think it's around 11 kgs now. About 6 months from surgery. He's planned for FOR along with distract removal. Done, no? He's done, he underwent, already,
So primarily you think that this kid was having raised ICP due to airway issues is what your thinking is? Is it what I'm kind of, because coming from someone who is a neurosurgeon, it could be the central raised pressure driving the sleep apnea and the respiratory problems. But you are showing us that when you do the airway, it kind of helps to reduce the central part of the CO2 retention part of the raised ICP and helps them to thrive so that you can come back a bit later.
Agreed. So airway should not be taken as and cannot be belittled when you decide the sequencing in these children. Now this was a child, go to slides again. This was a 2-year-old with airway issues, a proven cruising. What do you want to do for him? He had repeated URTIs. He's 2 years old.
It's peripheral sleep apnea rather than central, is it?
He had a repeated URTI from the complaints.
The workup.
So it could you would consider both central and ICP and obstruction.
Yeah, we would probably do the sleep study and ICP measurement at the same time and see how much is the percentage of the obstructive airway causing a problem, and then plan accordingly, because quite a few of them, what we have done is standard tonsil adenectomy. If there's a mid-phase issue, then tracheostomy, and then move on, is what our treatment algorithm is to work these children up.
Can you go to slides? He had frontofacial with internal distractors. Pramod, you want to comment on it?
Yeah. So we did monoblock distraction for him with using internal distractors, stabilized with the transfacial pin.
I think just now he's already under 7 years follow-up with mid-phase symptoms
coming back.
Recurring, yeah. So again, when you do an early mid-phase intervention, you expect a revision at some point of time. This was a different child, about a 13-month-old with this phenotype. We don't have the genotype available. This is the phenotype. Whereas the CT scan, I would just mention, the CT scan showed one-sided coronal involvement with probably sphenoid wing.
Child had severe respiratory distress. The child used to be left alone by the mother when she used to go to work, and then the relative who used to take care of her, used to manage, and she also had lobe subluxation on one side, if I remember.
Yeah,
yes.
So here the importance is it looked like a plagiocephaly, and the CT scan looked like a plagiosingle unicoronal, but the genotype picked up as was Cruzan.
Cruzanoid, yeah.
Yeah, yes. Exactly. So you might have an intuition of that, but then initial CT scan only picked up unicoronal. So that's why genotype becomes important for the whole completing the whole picture in many of these children. So he underwent phase later. So I'll just summarize it. So we are very aggressive on the timing of each of these surgeries. Sometimes we do PCVD, mid-phase, and FOR separately, and we move one surgery after each without looking into the timing of the requirements, believing that this is a functional concept, may not. So this is another child where you had a PCVD and then the mid-phase and the FOR later. So sometimes we have situations where we do PCVD first, and if the front aspect is not so bad, we do the mid-phase alone. So this child had a FOR much later, but initially had only a PCVD and a mid-phase. So and looked the first set is without FOR, and then she underwent FOR much later. And sometimes you require, the second child, the last 13-month-old, we did not do a PCVD. We did the frontal and the mid-phase alone. So that's the child. And then occasionally we have Cruzan, where you have a PCVD and then the frontofacial later as secondary procedure. So different combinations might need to be tailored according to their presentation. And we are gently aggressive, believing that all these have a functional contribution in their real long term. Thank you. Any questions and any comments from the panelists? Jag and Shailendra and...
Just a quick question. When you do the transfacial pins, do you do like a sub-Lee-4-3 type of osteotomy when they're older so that you get distance? It is something which, because of the relapse in the older age, when you have to go back and do the whole thing, do you kind of think of doing something slightly more, rather not transcranial, but it's just subfrontal?
So if we are doing a frontofacial advancement, which can be a monoblock distraction or a hybrid monoblock where we advance the cranium, fix it, and then distract the mid-phase. So in such situations, you definitely have to raise a coronal flap. But if we're doing just a mid-phase, then I prefer not to raise the coronal and save it for additional procedures, and then do minimal access Lee-4-3 osteotomy through lateral brow incisions and nasal midline stab, if required intraoral as well. And we do not completely mobilize the Lee-4-3 segment. I just complete the osteotomies in the very young children and then distract. We raise the only the lateral aspect of the coronal to fix the foot plate of the distractor.
So the one of the things that published in literature on monoblock and frontofacial is the complications associated with them. And do you have any issues related to that?
See, it's the way it is done. You know, we have not had leaks. We have not had ascending infections. The reason being, when we do a frontofacial procedure, I leave the anterior cranial base intact. The frontal, whatever frontal procedure is done above the nasion, that's the frontonasal junction, which extends back as the skull base, and the Lefort 3 osteotomy is performed below that. And then if you're doing a distraction, you wait for 5 days so that reasonable amount of fibrous or callus forms. So that prevents the leak or the ascending infection. And if you're doing an advancement also, you start distracting the midface later. So there is no way that if your cut is really above the frontonasal junction for the cranium and your midface cut is below the frontonasal junction, then it's a very safe procedure to do. The problem is when you go inside, from inside. If you go from inside, like when you do a hypertelorism correction, then you're opening the cranium and you're communicating the cranium with the nasal cavity. You shouldn't do that. Then it's safe.
And what happens to the root of the nose when you distract them separately?
Well, it's a very thin segment. It's like 3 millimeters or 4 millimeter segment that stays behind. You're getting most of the, and your root of the nose, if you do a Lefort 3 osteotomy, that is where you would cut. Forget about doing a monoblock. If you do a Lefort 3 osteotomy, that is where your Lefort, midline nasal cut is going to be. And if you do a FOR without a midface, that is where you would cut, is it not? Above the frontonasal junction.
Yeah.
I hope that makes sense.
That's, yeah.
Any questions and comments again? Last few comments, we're closing the session.
I have one, sir. Hey, sir. What is, can you just briefly mention your experience with ROSA in midface? And is there any, in your experience, any case where you had to like go for otherwise?
I think we had one failure, which mentioned that.
There's once, our issues with midface has been when the ROSA did not work. I had to freehand it. Now the issue, you need to remember these are very small children, right? So your purchase on the face is probably about 1 centimeter on this side and centimeter on this side. So even a mild deflection when you insert it, you will miss the other purchase point. You know, so if you miss the other purchase point, then you will have to make multiple passes, and then the bone will become like cheese. You know, already it's soft bone, so the chance that the wire can cut out is more. So that has happened once, but then there was another time period where the robot was not working, so I had to do 2-3 cases freehand. But I think now I have the hand memory probably, you know, so. But I would prefer to do it with guidance so that I can have the vector one. You must have noticed in one patient, there is a mild vector variation because the wire is not straight. So if there is a vector variation, you can have a large orbit with an ophthalmos on one side. So it is very important that you get a very parallel vector for your wire to be passed.
Shall we close the session? Yeah.
So this is how we do it. So you can exactly look at the purchase point and see the vector and design the vector using the software. You don't need it in older children, but when we are doing it in very young, then it's helpful.
Fair, I think.
Yeah, I think we should move.
Thank you for all of you for joining, and Dr. Shailendra and Dr. Jag, thank you very much again for at least.
Shailendra is staying back for the next session.
For the session.
Yes.
Thank you.
Jag, thanks again.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Suhas and all the panelists for that informative session. Next session is an overview on craniofacial trauma, neurosurgical perspective and traumatic CSF rhinorrhea by Dr. Apinder Singh, neurosurgeon from PGI Chandigarh.
Yeah. Good afternoon, everyone. So, craniofacial trauma will be part of the panel discussion. So, I'll be concentrating more upon traumatic CSF rhinorrhea, and I'll give an overview of the traumatic CSF rhinorrhea, so that just be brief discussion about it. So, traumatic CSF rhinorrhea happens in 1 to 3% of the closed head injuries. It is 80 to 90% of the times CSF rhinorrhea is because of the head injuries as well. And in 10 to 30% of the skull-based fractures, it is the CSF rhinorrhea happens. And usually it manifests within 48 hours. And all CSF rhinorrheas traumatic usually manifest within 3 months of the trauma. Brief about the site. The spontaneous CSF rhinorrhea, the most common site is cribriform plate, but that is not true for the traumatic ones. The frontal sinus is the most common site. The sphenoid is the second, the ethmoid is the third, and then the cribriform plate is the fourth in traumatics. And then the mixture of frontoethmoid and the sphenoid sinus. So on radiology, this is the frontal sinus, the sphenoid, it's not working, sorry, yeah. The ethmoids, anterior and posterior, I'll talk about it. And then of course the cribriform plate. Okay, so this is the frontal sinus which you can see. So again, a brief review of the radiology of the CT PNS in the lateral view. The frontal sinus, which has various pneumatizations, we will not discuss about it. Then we have the ethmoids, the posterior ethmoids. We have the sphenoid sinus. So first, the frontal sinus fracture. The frontal sinus fracture is divided into 3-4 types. The anterior only, the posterior only, the anterior and posterior mixed. And there is the leakage from the frontonasal duct as well. So that is part of the discussion of the panel discussion. So frontal sinus fractures, anterior as well as posterior, if you see, the management varies according to the type of fracture. We'll discuss that. Okay, and sphenoid sinus, you can see there is a defect in the sphenoid, and there is a significant pneumocephalus going from that, and sometimes the brain matter comes into it. The chronic leaks can have empty sella syndrome, which we can normally encounter. And then the ethmoids, anterior and posterior ethmoids, anterior are smaller ones, and the posterior one the larger ones. You can see from the coronal view that the green ones are the posterior ethmoids, which goes superiorly and anterior to the middle turbinate. And this is the fracture of the ethmoid sinus. Okay. Just a minute. Okay, so one thing I would like to mention here, in the fractures of the cribriform plate, you can see there's a fracture in the pneumocephalus. But there's a catch in it. Sometimes what happens, there's a minor head injury and the patient's having CSF leaks. So in that case, it might not be because of the trauma. So in that case, it might be because of the IIH, the idiopathic intracranial hypertension. So in that case, you need to see the symptoms of the patient, the severity of the trauma. So like in this case, you can see if there is during MRI, you see the empty sella, you see the optic nerve. The optic nerve head is enlarged and they are tortuous, and there's flattening of the optic disc and the posterior wall of the orbit. So if you see all these symptoms, then you need to realize that this is not the trauma, this is the idiopathic intracranial hypertension. And if you do a repair, it is going to come back because there is increased ICP and there is high pressure leak. So in case of cribriform plate fractures, you need to be very careful about it, whether it is traumatic or it is a minor trauma which is caused because, and there is already an underlying idiopathic intracranial hypertension. So that was the point I wanted to mention. So the next is the diagnosis. Okay, so there are some bedside tests to see CSF rhinorrheas. They are not confirmatory tests. One is Cook-and-Set test, that is IJV compression increases the rhinorrhea. Then we have reservoir sign. Patient is sitting down, you make the patient sit down from a supine position. Suddenly a gush of clear fluid comes through the nose. That is what is called as reservoir sign. The next, but that can happen in chronic sinusitis. There's clear fluid inside the sphenoid sinuses and the other sinuses. The clear fluid can come. This is not definitive. The other is halo or double ring sign. So when there is blood mixed with CSF, then you collect the CSF in the filter paper and you see a double ring. The central ring is of the blood and the peripheral ring is of the CSF. This is called a halo sign or a double ring sign. And then a handkerchief test that nasal secretion is sticky, they don't, but the CSF doesn't stick. But all these tests are observer dependent. This is not confirmatory test for CSF anuria. This can vary from individual. So what are the confirmatory tests we need to do? Okay, one is glucose oxidase test. That the CSF glucose has more than 20 milligrams, but this is not seen in nasal secretions. But again, if you have meningitis, the CSF glucose might reduce. So again, this is false positive. The most sensitive test to check for CSF is beta-2 transferrin and beta trace proteins. They're the most definitive tests to do for CSF. There's almost 100% sensitivity and specificity. And then we have intrathecal radionuclide tests or the intrathecal fluorescein scans. I will discuss about it. And then to localize the site of leak, you need to do an MR and CT cysternography. So the CT cysternography is showing the leak. The only problem with CT cysternography is it is invasive. You need to do a lumbar puncture, inject the dye and then check for CT. But in MR cysternography, it is non-invasive. You don't need to really put in a dye in that. So, okay, so now how do we deal with it? So, supposingly there's a suspicion of CSF leak. You can go in for nasal endoscopy and automicroscopy to check for the site of leak. And then there are two types of leaks, that is persistent high leak and intermittent leaks. So, persistent leak, you can collect the CSF in a specimen and do a beta-2 trace proteins. If it is positive, then it is yes, it is CSF. If it is negative, you can say there is no CSF leak, it is a nasal secretion or something else. You can observe the patient. But if it is beta-2 trace protein positive, then you need to look in for the cause of it. Okay, that is one scenario. So second is intermittent CSF leak. Patient doesn't have clear watery secretion from the nose or he is having a post-nasal drip, right? So you see whether you can collect the CSF in the specimen or not. If you cannot collect the CSF, if you can collect the CSF, of course, then do a beta-2 transferrin. Beta-2 transferrin will confirm you the CSF anuria. But if you cannot correct it, then you need to do a skull-based CT scan or MRI to look for the site of leak. So supposingly if there is CT scan is showing the site of leak, then you go for the repair. Open versus endoscopic we'll discuss later. But if supposingly it does not yield you anywhere, then you do an MRI or MR cysternography with CIS sequence. Again, it is not showing the leak because sometimes low pressure leaks doesn't come in the MRI or CT scan. Then you inject intrathecal fluorescein mixed with CSF in the lumbar puncture and see from the endoscope that you can see a trickle of the dye from the nasal side. So if at all you have a confirmatory site of CSF leak, then we go in for a surgical intervention. Okay, so now you have a leak, you have a CSF anuria, then what is the treatment protocol? There's some conservative management protocols and the surgical management. So conservative basic things, bed rest, head and elevation, laxatives, avoid straining, decreasing ICP measures like mannitol or diuretics or whatever the way you want to know that what is the ICP measurements protocol is. There is no role of prophylactic antibiotics in CSF anuria. The prophylactic antibiotics does not prevent meningitis. In fact, they are detrimental. They can cause antibiotic resistance. So if at all a patient is having a CSF anuria isolated with no other indication of antibiotics, please do not start antibiotics. 60 to 70% of the post-traumatic CSF anuria stops within 2 to 3 days, and 90% of the CSF anurias, post-traumatic I'm talking about, they heal within 7 days. So you need to give a conservative trial of spontaneous resolution of CSF leaks. So when to intervene? That is most important. If acute leaks are there, then first of all, take precautions as we have measures of bed and elevation, laxatives and all that. Conservative trial of 3 to 7 days need to be given. Supposingly that the leak is decreasing at day 3, then wait for 7 days. But if the leak is persistent at day 3, then you can go ahead for lumbar or ventricular drain according to the CT scan. If there is a ventricular enlargement, put in a EVD or lumbar drain if it is not contraindicated. So when is the scenario when lumbar drain is a LP or a lumbar drain is contraindicated? So I'll show you a scan. So the CT scan which is showing brain contusions, it's showing EDH and a pneumocephalus. You can see this. So if you'll put a lumbar drain in this scan, so it can reduce the ICP, the EDH might increase, or the pneumocephalus, the lumbar drain will suck in the air and it will cause increase in brain air. So this is called as tension pneumocephalus. This is called a Mount Fuji sign, famous by the Mount Fuji in Japan. So if there is significant pneumocephalus, don't put in a lumbar drain because it can cause tension pneumocephalus. Contraindication for a lumbar drain. Then even if with the lumbar drain, the leak is persistent for after 7 to 10 days, that is an indication for surgery. Open versus endoscopy is a debate. We'll discuss about it. So open versus endoscopic. When do you go in for an open surgery for CSF rhinorias, for CSF leaks? If it is indicated for other traumatic reasons like there is an intracranial bleed, there is depressed fracture with leak, and we have significant pneumocephalus, there is a foreign body inside the brain because of the penetrating trauma and you need to remove it, then go for a transcranial repair of the CSF rhinoria. There are multiple fractures with large effects, more than 1.5 centimeters indication. But here is a catch. Multiple fractures usually try to give it a conservative trial because if there are supposedly 3-4 type fractures at places, most of the times other fractures will heal and only one point will be leaking. So wait for that day, you look for it, where is the leak from the endoscopy or from the CT and MRI, and then go in for surgery. Or if there is a meningocele or a meningo, the part of the brain is herniating through the defect, then you need to do it from the transcranial report. Indications of endoscopic surgery, there is small defects or a single defect from the cribriform, from the sphenoid, from the ethmoid. And if it is from the frontal sinus, usually these days we are doing endoscopically. Traditionally it was supposed to be a frontal open approach only. So it's a small video. I'd just like to show that there's a defect in the front ethmoid. We're showing that this is a, can I fast forward it? Okay, so there was a meningocele, you can see that. So we were doing it endoscopically. Once we gradually remove it, you just make sure that you are not harsh enough because you can create other defects by yourself by causing manipulation. So you can see there's definitely a meningocele and there's a brain matter herniating through it. So you can see this is a meningocele over here in the center. The part of the brain is herniating through the defect. So this is a carburetor we use, this is a carburetor wand we use in endoscopically, and once we try to define, you will see a sudden gush of CSF from the defect side. So as we were trying to lineate and we were trying to where it is defining the defect. So this is the center of the defect, and once we'll just do it. So see, there's a sudden gush of CSF. That was the time, that was the place from where the CSF is coming. So you can see. Now, the most important point is you have seen the defect through the endoscope, small defect you can very well repair with the endoscope. The thing is, you need to define the dural edges. You need to refreshen the bony margins so that it heals properly. Just defining the defect and not putting a fat or it will not make it heal. You have to define the edges, you have to freshen the edges. And then of course you see the defect over there, dural margins and bony margins freshen, and then you put a fat and then of course the glue and the fascia over it. So this is the fascia placed over it and the glue. So that is what I wanted to mention here. This is the fascia we have put in, and we'll just augment it with the glue. Now the transcranial repairs, you can use a bicoronal flap or a Sauter's flap and a unicoronal flap as well, and then you make burr holes and raise the pericranium. And then there is two techniques, intradural or extradural. That is, you go extradurally, dissect the dura and then go inside at the base of the skull, or you open the dura and see it. The problem with extradural is, supposingly you are dissecting and you cause a dural tear by dissection. So you don't know whether this is a traumatic dural tear or it is caused by you. So it is one problem in there. The problem, so intradural is more robust construct, but the problem is there is a lot of brain retraction in intradural things. So both have its own pros and cons, and many people prefer both intradural and extradural. So it's individual choice, I guess. Okay. And then there's a problem with olfaction. So you need to see most of the times with the cribriform plate fracture, most of the times olfaction is gone. So if you really want to put in fascia over the skull base, you really need to compromise the olfaction, you need to cut the olfactory nerves. So if the olfaction is preserved, then the transcranial roots is a bit problematic. So finally, when to intervene is more important than what to intervene. Overzealous use of antibiotics is detrimental, it is not recommended. Acetazolamide is doubtful. So what we say is if the CSF leak has to stop, it will stop by itself. Acetazolamide can delay it, but it will not stop it, to be very frank. Then the approach is to be individualized and multidisciplinary. Thank you.
Thank you, sir. Any questions? I think no. So I request you to stay back for the next session. Next is a panel discussion on craniofacial trauma, multidisciplinary management. I invite Dr. Lata P. Rao, craniomaxillofacial surgeon from Aster Medicity, Kochi, to moderate the session. I also invite our esteemed panelists for the session, Dr. Arpinder Preet Singh, Dr. Vaibhav Deraj, Dr. Ashvi Chugh, maxfac surgeon from AIMS Rishikesh, Dr. Benny Augustin, maxillofacial surgeon from Rajagiri Hospital, Kochi, Dr. Arun Sharma, maxillofacial surgeon from Amrita Hospital, Faridabad, and Dr. Manu Mohandas, maxillofacial surgeon from Renai Hospitals, Kochi.
Yeah. Good afternoon, all. Panelists, with your permission, shall we start? So, craniofacial trauma, as we all know, is a grave injury in which the function, aesthetics, protection to the important organs are lost. And many a times, we may do more harm to the patient than the trauma had done by our wrong decisions or delay in the management. In our part of the world, road traffic accidents are the most common cause, and the high velocity trauma in what the patient sustain or get. Most of the time there are associated cranial injuries with respect to the facial fractures also. So the trauma to the face can cause, in addition to the fractures, trauma to the other important structures, and we'll be concentrating on the fractures which are important with respect to the management of the frontal bone, frontal sinus, and the frontonasal duct tract. So this case is like, I will quickly go through this because Arpit has very beautifully described how to manage a CSF leak. As a gentleman, we came with a sutured laceration on the forehead, and you can see a small depression which is masked by the edema right now, and with intermittent CSF leak. CT shows the leak on the lateral, sagittal, and the coronal section, and there is a huge depression in the anterior table as well. So the concerns here, I would say that is a CSF leak and the aesthetic part. Again, we have, like Dr. Arpita has already described, we have to kind of know from where the leak is happening before we start with our management protocol. Again, Dr. Arpita has said that there is a role for conservative management, means like you wait and watch for some amount of time. And for how long is the question where the maxillofacial surgeons always need to know from the neurosurgeon. When do you give us consent for going ahead with our procedure? So Dr. Arpita, would you say probably a week will be the best time to wait to know?
Probably a week for the conservative trial, but if it is active leak, supposedly, and not stopping within after 3 days, the leak needs to reduce. Then only you can wait for 7 days. But after 3 to 4 days, the leak is persistent and it is increasing. So that means you need to intervene.
So you mean to say, is no sign of decreasing the CSF leak? You might have to intervene even before 7 days.
Absolutely,
you
absolutely.
To do it.
Yeah. There's a possibility of Lumbarden also if you want to put after 3 days, but if there's intracranial injury significantly, then I think Lumbarden again as contraindicated. Yeah.
So there are a lot of articles which says why you should wait and why you should not wait beyond 7 days. So it's always a balance to get wishing for a spontaneous CSF stoppage, leakage stoppage, and the need to primarily repair our facial fractures. Lumbar drain is again has limited use in certain cases, but be very cautious with overzealous drain, which can worsen the condition which already is there. Medical management, would you like to elaborate a little bit on acetazolamide? What is it that's supposed to be doing?
So there are mixed studies basically for the acetazolamide. Some people propose to be that the acetazolamide should be started. But as I said previously, that if the leak has to stop, it is stop without acetazolamide as well. So there are some publication, as you have said, that acetazolamide reduces it, but not exactly followed.
Yeah,
I really don't.
Majority of the studies have shown an occurrence of metabolic acidosis and hypokalemia with uncontrolled use of or prolonged use of acetazolamide. So we have, panel, can I say that it's a case for a surgical intervention? Because Dr. Ashi, in your unit, what will be the management? We know that we need to repair the anterior fossa and do an ORF of the supraorbital rim. So what will be your option for the
Yes,
ORF
so
of the bone?
normally if we feel that the cranium is exposed or the brain is involved, then I mean we partner with our neurosurgeons and we manage it. But if it's just the anterior table which is fractured, then we just would probably use mesh or bone plates to get it back into position.
Okay, in this particular case, we have already seen that both the anterior and the posterior tables are involved.
Yeah, so then
Leak is happening.
Leak is happening.
The leak is
yes.
happening. So obviously we would go in with the neurosurgeon. I mean, I'm very happy that we have our neurosurgeon on board. I mean, he's here with us today. So
Okay,
it's always in collaboration with the neurosurgeons, and that's how we do it.
So we all agree that these are the options for the, and then in this particular case, is mesh a better option than a plating and wiring? Manu, if,
I think I would try to get the bone fragments in place first, if they are viable and if they seem steady enough, and mesh would be my second option.
and Dr. Arun.
So I see the segments are quite big, so I think we would use plates as many as required, probably to stabilize the whole of the anterior table. Also, I see there's a fracture in the middle orbital wall, so I would assess the patient because the patient's eyes were not open. So I will look for any defect in the orbit or maybe an ophthalmos or diplopia in one particular gaze.
Yeah, in this particular patient, we had got the ophthalmologist examine him, and there was no restriction in the eye movements.
And sometimes if it's too comminuted, then you might have to go in for a mesh because, the fragments would be too small to play.
Further devitalization of the fragments could be avoided, yeah.
But since there is leak, so we probably need a cranialization as well, along with that, because the posterior table is fractured, there is pneumocephalus, you can see there is a bit of pneumocephalus.
So I just want, because for me in the beginning part of my career, I was always confused about those two terms, obliteration and cranialization. Would you throw some light onto that?
So basically obliteration is mean that you remove the mucosa and everything from the sinus, and then you obliterate the frontonasal duct with fat or glue or any muscle or the fascia. So that is the obliteration. But the cranialization means that you remove the posterior part of the sinus, frontal sinus, the posterior table, make it a single construct, and then put a fascia or the fascia over it, and you separate the frontal sinus from the dura. That is what is you remove the posterior table in case of the cranialization.
Okay, is there any, like from the CT, you can say that whether this case will require an obliteration or whether it will require are there any criteria like that?
Yeah, absolutely. If there is anterior as well as posterior, table defects with the dural tears, that is a case where you need cranialization mainly, or with the pneumocephalus. But if it is just there is no dural tear supposingly, and you want to, there's an obliteration of the frontonasal duct, then you just need an obliteration.
Okay, so we can can we say that this is how it is, the protocol is like, when there is a severe posterior cranial fossa fracture, posterior table is comminuted, you might decide to do a cranialization.
I just wanted to ask one thing with Dr. Rapinder. In this case, although the anterior table looks like it's a comminuted fracture, the posterior table, it's not a comminuted fracture, right? So would you still do a cranialization in this, or probably just do obliteration for this?
Okay, obliteration is fine, but there's CSF leak actually. So I would at least put in a fascia over there, if at all not complete cranialization. That we can that alternate still we can give, but we need to put something between the dura and the sinus. The leak doesn't happen because leak is happening. So that is the point. So leak has to be stopped. So there are two things again. That is what. Yes, you can do that you don't remove the posterior table at all, but you obliterate it and then put in a pericranium or a fascia, tensofacial lateral. That's what.
I just wanted to ask one thing. Whether suppose the leak has stopped by 7 days,
sir,
then do we have to do anything? Just an
no, sir. There's no need to do anything about it. If the leak is stopped, then I think we can wait. Yeah.
We can just cover the.
We can do an aesthetic part of the. Yeah.
No, when will you do the aesthetic part? The leak has stopped in 7 days' time. When do you address the aesthetic part will become the next question.
That can be done, no problem. The edema subsides.
Immediately, or do we wait for some time and then do it later?
Anytime, I think there's no problem in that.
Oh, you
The
mean to say
need
that
not to be
after
over aggressive, that don't.
Aren't
मतलब
there
the
any
leak.
risk that we might dislodge the posterior table?
If you are dealing with only anterior table, then it's not a problem.
Yeah, no, with this case, which had a posterior table fracture also.
That's a tricky thing, but I agree that. But
Yeah.
In
Okay,
yeah.
okay. Fine.
Wait for
Yeah.
some more days.
Yeah,
Early
no,
as possible.
so
Okay.
at least for this fracture is the only area where we don't mind waiting for some more time, because these
Exactly, yeah.
defects are amenable for a secondary correction. Very good. Whereas the other facial fractures may not.
You would also want to actually know that the leak is coming only from one place.
Yeah, exactly.
Yeah.
if there is gross combination of the outer table and the inner table is intact, and we are going in for a mesh or a custom plate or something, so are we just obliterating the sinus alone? We're not. We don't have to remove the lining, or we just have to obliterate the duct.
Actually, initially it used to be that you remove all the parts of the sinus, and so that it doesn't cause mucoseals or infections. But these days say that the mucosa is absolutely intact, supposedly, and only the fracture is there, then you can leave it also. This is a recent one. But otherwise, classically, if you ask me, if you want to obliterate it, you remove all the contents of the sinus and then fill it with whatever material you want.
So there are a lot of literature which shows with the incomplete removal of the frontal sinus mucosa or obliteration, there is a possibility of recurrent infection in the frontal sinus. Repair of dura, Dr. Arpit again had described it very beautifully. But one question which I wanted to ask was, you mentioned about extradural and intradural procedure. So what is the criteria for selection of how do you decide which one will be required for the patient?
So normally, if you are lucky enough that you are able to repair the dura primarily, because it is really not the case.
Yeah, that may not be the case in all.
May not be the case. In fact, an attempt to cause dural repair, you can cause more dural defects also. So that's why there is need of putting a facial atta or a pericranium.
Yeah.
But if you can primarily repair dural tear, nothing like that. Absolutely nothing.
No, between the intradural and the extradural,
Again, a matter of debate only. The intradural component is more robust because you can directly see from where it is coming. But if there is a brain injury and acute trauma is there and the brain is swollen up, supposedly, so it causes more retraction of the brain to see the defect. So you can cause more injury in edematous brains. So the extradural is more protective for the brain, but intradural per se is more robust, a construct.
Okay.
That
So
is,
you-
it is. Yeah, exactly.
Flap.
Because of the pressure.
But then it is done with the pedicle pericranial flap itself. The intradural. Free also, okay.
Pedicled one, yes. The only problem is if the defect is very posterior, then you have to go through the olfactory tract. And so olfaction sometimes goes permanently.
Okay, yeah.
So you need to check the olfaction preoperatively, and if the olfaction is intact, then that's a problematic thing. I mean, not problematic, but I mean, you have to think about it. Yeah.
Okay. So this is what we did. We used a mesh reconstruction for the bone, and the pericranial flap was tucked in extradurally, of course. A very short, almost like not a very short case, it's a very long case actually. I wanted to say long case. He was shifted. No, these meshes are have closed, the loop or the holes are quite close by, so they don't give out that indentations. The regularly available meshes are have big holes into which the skin can get stuck. But these meshes you can see the holes are quite close, and the area between the holes have broad metal, so the tissue doesn't get stuck.
Which company was this, ma'am?
Indian company. We have a Jayon. This is a Jayon mesh. It's based in Kerala only.
We have the pericranium over this, then this indentations may not show much.
But the pericranium will go between this. We had to cut the mesh into two for the pericranium to pass.
As the flap is thin, and then this can be a problem, as sir said. Absolutely, I agree that, particularly in children
So
also.
the bigger portion of the mesh was covered by the pericranium. Only a narrow rim remains on the top. So he was brought in from another hospital after decompression. And facial bone fractures with a lot of orthopedic injuries also, and he had pneumonia. And on the left side, he had CSF leak and the third nerve palsy on the right side, which was detected, of course, later. He came on a ventilator, and you can see how badly comminuted his facial fractures are. And a huge pericranial flap was taken out for the decompression. Temporal parietal and frontal flap was removed. So the concerns here will be leak, protection to the brain, function and aesthetics. And these are the fractures which he had: mandible at 2 places, maxilla, comminuted zygoma, and comminuted supraorbital rim and right lateral wall of the orbit. And very unfortunately, the patient's bone flap when missing either was not preserved at the previous hospital or it was lost during transit. We never received the bone flap in our hand. The panel for the surgeons, I would like, whom do I call now? Can you start, how do you start, Manu? How do you, what will be your thought process if you get a patient like this?
Yeah,
you need to plan first, right?
So we need something as a base, right? So we start from the bottom probably. And that is how, I mean, since it's a panfacial fracture with a condyle, you'd probably want to address the mandible first and, get a stable base on which because occlusion is the basic thing. You need to give function to the patient. If you don't have a functional occlusion at the end of your surgery, there's no point operating. So I would probably do the mandible first and go for something called the bottom to top approach. Start from below, but get the occlusion intact.
Dr. Binu.
Yeah, since the cranial part is involved, it depends on whether you are addressing the cranial part. So most of the neurosurgeons doesn't want us to operate simultaneously. So we would take it in 2 steps. The cranial part, so it can be done, the mandible can be done first, and then the IMF can be put, and so you get that lower mid face correct. And then you finish off then you close everything down, or even the mouth is closed, and then the neurosurgeon comes over and he does the cranial part, and then we fix the frontonasal area.
You have to separate the oral cavity from the cranial cavity, right?
That's what
I meant. Prevent
cross-contamination. So you put the frontonasal area correct, and then the frontozygomatic area also put that into position, and then once that is done, then you come back again.
Yeah, in addition to the top bottom or bottom up, there is another approach where you start from bottom, finish the mandible, then start from top, come till the infraorbital rim, and the last step will be the maxillary buttresses.
Yeah, the leaf-out area. So there is another way also.
But 2 things I like to, one is, the patient is post-cardiac arrest.
Yeah, post-cardiac.
So the most important is the DCS of the patient. What is the DCS he's carrying on? Supposedly his DCS is 4 or 5.
Yeah, that I was about to, how do you give fitness for the patient for surgery in this particular patient?
No, I agree that the maral occlusion is important, but first of all, if you look at CSF leak, the CSF leak is happening, then I think that is the first one to be addressed before anything else.
So this is once the patient has recovered, right?
Yeah.
I mean,
Yes,
not that we are
stable enough to undergo a long procedure. Yeah.
Our intervention comes in much later after the patient is stable. So obviously, once the pneumonia, you said the patient has pneumonia, the pneumonia settled, and the CSF leak is, and when you're comfortable, probably then we should take over.
So here, one thing which I would like to ask our neurosurgeon is, was there any chance of I'm just skipping a few slides here. Was there any possibility of doing an ACF repair at the time of decompression? Whether they could have done that?
Absolutely. They should have done it. I don't know whether, if the CSF leak is happening, that means it has not been properly done. Okay. Otherwise, see what happens if there is a panfacial injury as well as there is injury to the scalp as well. So you don't get a good pericranial flap, pedicle flap, because it is torn in between because of the skin defects also. So then you take a tensor fascial if at all require, or a artificial dura, whatever. But yes, if there is a injury in bifrontal decompressive craniotomies you do, and you suspect a skull-based fracture, then, and if the patient is hemodynamically stable, if the patient is hemodynamically stable, that is the most important time, then you do an ACF repair. If the hemodynamically not stable, then of course then you have to.
How soon or how late after an ACF repair can we attempt our fixation in this patient? Because he has a central midface and the lateral. We might kind of disrupt your ACF repair.
So then we need to wait for the brain edema to settle. What happens that, as Sir has said, that once there is brain edema, The brain is stuck to the skull base. There is no space for the CSF to come out. Once the brain relaxes after some times over 15, 20 days or 1 month, before that, then there is a space, then the CSF leak starts appearing. So we need to wait for at least, see, if there is no bone, then you can see the bulge here, like in AF, anterior fontanella. So till the point the bulge is settled, I think you should wait. And that is the point.
Can I add something for that?
Yes, at that time.
No, but at the time of decompression, which is kind of an emergency procedure, is it okay for us to come and do our part?
The initial surgery, the observation team is available, they will also come in. They also do, because just many blood fixation, whatever they can do, they'll keep on doing it. So, because you're utilizing that anesthesia to make as much as progress you can make, and then of course you will have to go in again. There's no point.
So that makes sense.
Yeah, Dr. Lata, I wanted to add on the same point is if they're doing an ACF repair, it's probably the best time to also just at least stabilize the NOE part of the
NOE
fracture.
part, yes.
Because if we have left the CSF rhinorrhea to resolve by itself for a week and not done an ACF repair to correct the CSF, I don't think we'll be able to go and again meddle with the NOE.
With the NOE region.
Because it will risk again doing a CSF leak.
And in the facial injuries,
You might even open the spontaneous closed CSF.
Absolutely.
Yeah. So NOE is the most unforgiving of all the fractures in the facial skeleton.
That's
I
true.
would say.
An advantage of doing that, what you just mentioned, sir, was if you properly fix the fragments together, initially the fragments, then the chances of a leak subsequently are reduced.
Yes.
Another thing which you need to consider is if the edema, the facial edema is so much, the soft tissue edema is a bit too much, and the patient has come to you after some point of time. So then maxillofacial intervention becomes slightly more difficult. But as far as the bony architecture is concerned, yes, getting that those pieces into place helps the the CSF leak recovery as well.
Is there any contraindication in giving steroids for the edema? Most of the time it's a...
What's the indication of, first of all,
cranial
no steroids for cranial no steroids.
No,
Steroids are for respiratory indication, other indications, because that will probably only do more harm. And number of studies have proven that.
It's doing more harm than what
do more harm.
Okay, fine.
And for brain edema also, in head injury patients, steroids don't work. Steroids work in tumor edemas. So to reduce brain edema in head injury, I mean, there are types of brain edemas we describe. I think that's not part of the discussion. So steroids don't.
So coming back to the hardcore maxillofacial region, Dr. Arun, would you want to take that question? In a multiple injuries or fracture of the mandible, where do you start reduction and fixation from?
In the mandible itself?
In the mandible,
there are multiple fractures?
We are thinking about the mandible fracture. We discussed that we'll do the mandible first, right?
So if a similar scenario is there where there is a unilateral condyle and symphysis, I would probably get the parasymphysis fracture reduced first.
Any particular reason for that?
Because we have good bone contact in that area and it is easily accessible. So I would probably, and I can assess the occlusion well compared to the maxilla. If there's a palatal split, then it's a different scenario. Then it's a more complicated
we are
situation.
focusing only on the mandible. Between the condyle and the parasymphysis,
I would go for the parasymphysis
first. Any difference of opinion? Dr. Vaibhav, Binu, Manu, Ashi?
Difference of opinion, I would agree with what Dr. Arun is saying. Probably do the dentate, but there's another school of thought which says that if you do the condyle first, I mean, that's what we've read as per the AO principles, that we do the dentate first. But there's another school of thought which says that, I think you've got literature.
Yeah, there are a lot of literatures for and against doing these things. And for the people who advocate for the dentate segment first will say like the getting occlusion is the most important factor. But then there are a few literatures coming up which say that condyle needs to be fixed first for the much more easier for the reduction and fixation of the segments. Dr. Bin.
For me, maybe the dentate segment first. It's because I can actually stabilize the mandible, pull the mandible down, so that I can easily reduce a condylar segment.
Making the mandible a unit, dentate segment a single unit will help in reduction of the condyle. Won't you have to apply more force to drag the mandible down if you fix
the patient is under anesthesia, and then the muscles will be relaxed, so you can easily, I mean, whatever force you are using for a single segment is the same as, as a full
so it's
segment.
I would say that it's an individual operator's choice here. And how do you get the transverse width correct? the mandible is played out. Dr. Vaibhav, you want to answer?
Yeah, I'll also start with the previous question at the risk of annoying many people here. Is that in the past 12 years, I've never ever fixed a condyle. So my concept, which I have learned through my training, has always been that the condylar area is pretty sacred and I don't want to touch it. And I usually do a flexible IMF and fix all the other fractures of the mandible. And to date, with all the follow-ups that I have had, I have had probably less complaints from the patients whom have left the condyle alone compared to people who have had the condyle fixed by some sort of IMF. I might be contradicting, this is my point of view.
To fixing the condyle is to get the posterior vertical height right and to get the projection of the mandible. When the condyle fractures and undergoes displacement.
Absolutely. I mean, there are some scenarios where if the condyle is totally dislocated and completely out, but I don't stick to the 30-degree criteria, is what I'm telling. My threshold to touch the condyle is very, very severe.
If we stick to the principles, if it's a panfacial case, we do the condyle first to get the vertical dimension and to get the functional occlusion back.
Either first or
so
the second,
first, in this
you
case,
have to fix the condyle is what?
I mean, it might work in your hands, but we are here, I mean, we talk about the principles here. So the basics say that you should do the condyle, which I think should be done in this case.
So gonial angle flaring, the question remains.
Yeah, so the gonial angle flaring, you want to take that? Sorry.
Gonial angle flaring, I mean, when we actually reduce the fracture, I make sure that the compression at the fracture segment is absolutely, I mean, very, very rigid so that the fracture segments don't go back. But I actually, again, I want to make another point that we usually don't treat the CT scan or the X-ray. So I accept a little bit of kind of the posterior flaring and go for the occlusion alone, because occlusion is what we are trying to achieve with this fracture fixation. So obviously I do every steps that are required to make the compression of the fracture segment absolutely rigid.
The lingual flaring which you just mentioned is what is being shown in this picture. So what happens on the dentate level? Do you want to make a comment on that diagram? Do you want to explain it, Arun?
Yes. So it is very important that we address the flaring and get the right gonial width, especially with bilateral condylar fractures. You may get away in cases where there is only a unilateral fracture, but if there's a bilateral fracture, then even with a 1 degree flaring at in the anterior region, the posterior flare may be quite significant. So it's very important that we do address that gonial width and the lingual flare. So what I would do is I would make sure that my occlusion is absolutely spot on from the incisors up to the second or the third molar, because when there's a flare, then probably the last occlusion in the second or the third molar would be slightly buccal. It's very dental to understand this thing, but this is one thing. And the other thing is I would try to look for, if possible, the lingual surface of the mandible. If none of if both the things are also fine, and the third test I would do is probably overbend the plate.
Overbend the plate.
And then first I would approximate and then give a overbend at the midline. And this is what we do.
So I search for a resident who's got good. Sorry, sir. Please.
Yes, sir.
Sometimes if you like compress it too much anteriorly, it opens in the lingual. So that you have to be very careful about.
On the labial surface, it will creep a little bit.
Yes. A few patients where it looks very good from like anterior view, but there's a flaring in the.
It's like a compression here, and at the gonial angle will help. So one question which I want Arpit to answer is: you have done a decompression, we have done our fracture fixation, but when is it the time that you keep the bone flap back? The flap which was removed in the...
If not specifically indicated, after 3 months. That's usually we follow, that's what called cranioplasty. So how do we assess?
Yeah.
First of all, the most important point is the relaxation of the brain edema, first of all.
Okay.
So if the brain edema is settled with the CT scan and with the obvious clinical appearance, then we wait for the 3 months, unless you need to address it before for any specific indications.
Yeah, okay.
Standard is 3 months for any cranioplasty decompression per se.
We don't have a bone flap here. What will be our choice of
Two choices, I think. First is mesh cranioplasty, which is you have.
Yes, that I'm winding up.
And second, these days you have tailored,
Custom-made meshes are
yeah,
Speak
custom
an
made,
option here.
three-dimensional. Yeah,
Speak
absolutely.
an option for that. Yes.
Can we use bone? No. Is this bigger defect? Can we get bone from anywhere else in the body?
No, we
Yeah.
can't. That will not provide a good cosmetic, I think.
In kids, we might want to go in early because of the bone resorption if it takes in that.
In
Yeah,
adults,
but in this
there's no bone here,
patient,
no,
we
sir.
didn't have that bone flap with us.
There's no bone here, sir.
Yeah.
That happens more in pediatric patients. That's 2-3 months is fine.
Okay, so shall we call it a day? Pramod is giving me all signs of. Thank you, Pramod. Yeah.
Shailendra is meeting online and there are people who are here.
Yeah, so just to summarize, I'll just put one last slide. To summarize, what I would like to say is the facial injuries are very, what you say, time-sensitive cases. So timing and sequencing is very important. Otherwise, you end up having deformities like this, where the orbit or the NOE was not addressed because of a bad census, or GCS was poor, or the patient was not stable. So timing is very important, and the happy period or the safe period will be 10 to 14 days from trauma. And you have to have a discussion with your team members to know and to sequence between these procedures how to fit your facial fractures in. Thank you.
Thank you, Dr. Lada and all the panelists. Next is an online session, an overview of encephalocele by Dr. Shailendra Magdan, neurosurgeon from Oxford, UK.
Good morning. I hope you can hear me. Can you-
Screen on. Shailendra, thank you for joining us on a holiday and spending so much time with us.
I think
Never say no. You're always the first one to say yes for anything. Thank you so much.
I think the cricket is keeping me awake as well. It's not a good news, but good morning. Thank you, Suhash, and thank you, Suhas and Deepesh and everyone in India. Really, it is always a pleasure to come back and kind of thinking about when I left to UK, and then thinking about the concepts of neurosurgery, the concepts of treatment, the things which we used to do, and now how much we have progressed in the thinking and managing our patients and giving them the world-class care is like completely eye-opener, and I kind of appreciate the things you're doing. And just a couple of comments that I have learned that one of the thing about acetazolamide is it shouldn't be said that it's not effective. If you've got a leak which is a very low pressure and a slow leak, then you can still do acetazolamide and manage it conservatively. That's my experience from encephalocele management. And I think the dosage also is very important. Means we do, I would say, a placebo dosage. If you're just going for 10 milligram per kilogram, you can go up to almost reduce to 50 or more than that. So kind of, it's not something to say, oh, it doesn't work. And sometimes you have to think outside the box, and you don't have to always wait for 3 months to do a cranioplasty. If it's a young patient who needs to go stop the sinking flap syndrome and other problems, you can do an early cranioplasty as long as you are happy there's no wound problems and you can repair something quickly. So just a quick thoughts. So I'm going to talk about quickly encephaloceles, and then we can, I hope, is it sharing the whole screen or just half the screen? Yeah. So I'm going to give you an overview. Means my experience. If I talk, I will probably go on for a long time. So please stop me when it's necessary to stop me. The quick thing is that just for education, it's a congenital neural defect. You can get all these things coming out through the defect, but if there is just brain, then it's an encephalocele. It's pretty simple. One more thing is that it is not an emergency. Those with skin ulceration or CSF leaks need rapid surgery to avoid meningitis, but you can wait when the child is older so that you get a better volume of blood and more risk-free surgery to to do the proper reconstruction because it takes time to put everything back together with two people, more than one person operating with craniofacial, maxillofacial, plastic surgeon involved in this kind of repair. The surgical goals: closure of the defect, watertight dural closure, and bony defect reconstruction. Etiology is obviously a congenital defect. Some cases can be acquired due to tumor, trauma, or iatrogenic injuries, and they can have a defect in, like, if you get a CSF rhinorrhea which heals incompletely, and then with the pressure, the brain gets stuck to it, and then over a period of time, it keeps on slowly getting bigger due to the inherent pulsations of the brain. And a skull base injury can lead to an encephalocele formation 4, 5, 10 years down the line. In adults, mostly, you can see that over a period of time. Why they say these are part of the neural tube defects where there is incomplete separation of the ectoderm and the neuroectoderm. But if you think about that, then they should be mostly a bit, they can't be covered with skin. So there is something else which goes on where you have a skin cover with the brain protruding out. So it must have happened after the skin has been closed. So there might be some abnormal genetic or signaling pathways that lead to this problem. That includes genetic factors, and also environmental factors are important because you can see these defects more in the sub-Saharan Africa, Asia, and the developing countries. I would rather say not developing, but the new terminology I've started using is the countries which are rich and the countries which have become rich because people have robbed other countries. Maternal use of folate and incidence of encephalocele is still not clear. They do represent 20% of all neural tube defects, and estimated 1 in 10,000. But this is an estimate which depends on the live births. What happens to the kids who are antenatally picked up? They tend to get terminated in Western world, probably a bit more or so in our countries as well. If there is a significant defect, it's very difficult to prove. This, but if you go to Africa where there is no antenatal checkups, in Ethiopia there is about 20% incidence of encephaloceles. Once again, with the neural tube defects, sex predominance is female and more pronounced in encephalocele, more likely to have an occipital encephalocele, but the frontal and sincipital encephaloceles are more common in males. And they are more common in, again, the sub-Saharan Asia or Africa countries. And in some of them are very common in some particular parts of the African countries, don't know why. Looking at the statistics available in India, it's very variable, with some reports showing up to 60% of occipital encephalocele, while other reports saying occipital encephalocele can be as low as 26%. Problem with separation is there. The problem with the causes could be because of problems with separation due to amniotic band or abnormal gene signaling, as I said, causes the anomaly to have due to primary neural closure problem. Quick word on treatment and management is you repair the bone defect with a watertight dural closure, eliminate the excess skin, and remove the non-functional brain tissue. The important thing is that when you're starting to remove the excess skin, do not throw the skin away. Just make sure that the excess skin is around till the end of your closure, so that when you find that you've got adequate closure, then you can eliminate the excess skin. Excess skin is always beneficial. In young infants, facial skeleton will remodel substantially. So you need to think about that. You just initially, if you do good repair, you can get a very good looking outcome as well. Most of the things, in my experience, what we have when I go to Africa to do the work is frontoid model or sincipital encephaloceles. Most of the work done in UK is now occipital encephalocele. So I got kind of, probably, I would say, not the best of both worlds, but I have experience in both the things. And it can be the craniofacial basis, the working with craniofacial maxillofacial surgeon is really important in managing this. You can't do it alone. I've seen neurosurgeons do it just by the frontal approach and pushing everything in. That doesn't work. I have repaired those recurrent residual swellings because you're not corrected the facial skull base or the defect properly. They keep still looking the way they should not look like, and there is still risk of CSF leak and meningitis. Operation is for prevention of infection and ongoing and future complications, which include cosmetic, visual, and psychological. You can have both exposure like bicurnal and direct, and then you can see the images here. So I've done a bicurnal FAP and then gone directly as well to reduce the defect from the front. So once you separate from the top, you have to reduce the cosmetic defect coming through the wherever it's coming out through. The herniation, the dura is thinner, it's not osteogenic, so you leaving that dura doesn't allow a new bone to form, especially in kid. The veins, which is herniated, is completely disorganized and very non-functional. Small ones can be invaginated. Hopefully, if there's no driving pressure, then you can wait and watch till they get older. Largely, you have to do an intradural repair. Why you can see that here, how the brain is abnormal and herniating through the wider nasal bridge and a completely abnormal brain. That needs to come out. You have to correct the skeleton because you can see the nose is such a long nose due to this deformity that you have to reduce the size of the nasal length of the nasal. And laterally, because of the pseudohypoterorism, you need to put the canthi back to where they are. You have to remember the long nose deformity and downward displacement of the canthi. What I learned is that once the fronto-orbital encephalocele is reduced and the bar is taken out, you reduce the volume of that frontal anterocranial fossa a lot. So you can get a dramatic reduction in the size of the anterocranial fossa, and that helps you in reconstruct and push the frontal orbital bar backwards to get a good recovery. You can see that this is the orbital bar coming out. I have used the excess bone and put it in the gap here. It's fixed with few screws. And laterally, we have used some plates to kind of give a good reconstruction with the nose being reformed with the bar where it was widened in the middle. So this is what we have done over a period of time, that we have modified the technique, and we, with my colleagues who come from Australia, David Chong, who is a cleft and craniofacial surgeon, and maxillofacial, we have modified our technique, and this is what we have done. We have reshaped the bar and put it back and given very good outcomes to do that. Because we push everything down and backwards, it helps in getting a very good cosmetic outcome for this. So you have to lower the frontal bar at once and rotate it. So that helps in kind of giving a very great cosmetic outcome like this one. So you can see that this bar had a bicurnal and a direct frontal incisions, and you can see how much beautifully you can reconstruct these things with time and give them time. And all the patients which we have done always have acetazolamide is given pre-op and continued for at least 3 to 6 weeks or even 3 months down the line. You can see how massive these defects can be and how you can put the bone back in there and reduce the frontal bossing and other things, and you can achieve a very good reconstruction if you go back. This boy still has a slightly longer nose, but I think as he grows, he'll get better. You can see various other examples of various complex herniations which can be corrected. That's what I was saying about excess skin. Keep the excess skin, use it, and then later on you can change it. You know you need an MDT for this. You need neuroplastic, MaxFax, ENT, intensivist, neurologist, endocrinologist, cardiologist, neuro rehab, and geneticist for managing this. And I think we are coming closer to that in achieving that in our country, in India. So that's my brief overview. Thank you very much.
Thank you, sir. Moving on to the last panel discussion for the day on timing and management of encephalocele, craniofacial clefts, and hypertelorism. I invite Dr. Ghosla Srinivas Reddy to moderate the session. I also invite our esteemed panelists, Dr. Shailendra Magdam, Dr. Sherry Peter, Dr. Krishna Sharma Rao, Dr. Madhubari, and Dr. Anurag Sharma.
If anybody is leaving early to catch a flight or something, your certificates are on the table outside. Don't forget to collect them.
Very good afternoon, ladies and gentlemen. I'll come straight to the next slide, please. I would like to show 3 cases, and the concept of the discussion would be based on the primary thing is on growth, timing, and the management. So the first case which I would like to put up on is, in fact, these are the 3 things which we have not been discussed all over the last 2 days, in fact, because we have been talking a lot about the cranial component, the craniostenosis, but this is a proper cranio-orbital area, that is hypertelorism, encephalocele, and most important is a facial clefts. So to start with, we have an hypertelorism, which has been a young boy. Now let us first look into it. I'll just take you the series of what was done for it. Based upon that, we can start discussing what is the appropriate timing that they should be done. Next thing is about the growth, and then the managemental aspects, what can go wrong, and the relapse part. Now we can see here it's quite a very wide, more than around 4 centimeters of hypertelorism involved in that. And these are the radiographs, and this is the planning which we have the STL model done up, and this classical intro. You can notice that a good rigid fixation was done, a good positioning of the canthal ligaments and everything, and the soft tissue excision, especially the voodoo, and the midline skin has been excised, everything. So it started off, the presentation of the patient was when he was 3 years old with a classical facial cleft and with an hypertelorism. So now the thing is, when would be the appropriate timing to start with? Is it the soft tissue or a combination of both soft tissue and the hard tissue at the same time? Of course, I would like to start with my teacher, Dr. Krishna Shamrao, who has taught me these principles way back in 96 onwards.
I've always tended to start early. So whenever the child presents to you with this problem, would be the right time to treat it. The earliest I would, I tend to treat hypertelorisms around 1 year of age nowadays, which many people feel is too early. And Sherry is already laughing, so that makes the subject very interesting. I believe that it's a lot to do with vision, it's a lot to do with function, and also aesthetics as a last component. Aesthetic component, of course, can be handled again better in an older age. When you operate early, you may have to redo the procedure when the ethmoids pneumatize, and there is a degree of relapse, and then you need to redo the procedure. The nose also doesn't look perfect no matter what you do, and you have to redo it when the child is an adolescent or an adult. So this is where I stand.
When it comes from the neurosurgeon point of view, to try to do it early at age of 1 year for any neurosurgical issues or complications that are encountered, because this is a more of an aesthetic procedure, not a non-functional aspect, because there is no increase in ICP, there's no respiratory distress, there's no functional aspect except on vision, unless it's a very wide, extremely where the child is going to have monocular visions, like very separated up. So that's quite very rare cases. Most of them, they do have standard binocular visions. So what are the indications that we would look into as a neurosurgeon?
So our role in neurosurgeons per se, our role is mostly supportive. We are actually trying to safeguard the brain when the surgery is happening. Correct. So the decision making, I would say that before the school going age, at least if you can correct by that time. So as soon as the child is fit enough to withstand the procedure, I think that would be, this child is probably going to need at least 2 or more procedures, right? So first procedure, if we can do it as early as, and at least let the child incorporate in the society with other kids, it will help the psychosocial component of the development will take place. And I think that one last surgery would be needed at the time of adolescence when all the growth and all when you need to fix the proportions, that's going to happen then. But the decision about timing, I think I would leave more to the parents per se, explaining that that this is going to be a long sort of a haul of management. It's not going. One person is not going to treat this thing.
Dr. Madhu, I was just wondering what could be the sequence? Is it the soft tissue correction first or the bony corrections first? Which would you think that start as early as possible?
I think as a plastic surgeon, I would actually leave the tissues till the last, because before I cut, I need to make sure that the soft tissue is ample in presence to drape up the osteotomy segments. So I think I'll leave that for the, during the time of box osteotomy, then I'll plan for the definitive soft tissue repair. Not before that.
Suppose we are trying to wait till the child is going towards the school age, like let's say put around 6 to 7 years when they're really going to the school class, where they're the first grade or second grade. So till that time, do you think that we can leave the child with a facial cleft like this, the soft tissue defect like this?
So I think, sir, if you are planning for an aesthetic outcome, for a psychosocial reason, if you are planning for a surgery, I think we should plan both of them simultaneously in the same sitting. I don't think there's anything that is preventing you from doing the box osteotomy simultaneously with the soft tissue correction.
Right. Now, coming to the box osteotomy, this to you itself, Krishna, in fact.
This child has a cleft, and facial bipartition would be the treatment of choice rather than a box.
So now coming to these osteotomies, like we know that we have three. One is box osteotomy, the other is a spectacle osteotomy, and the third is the facial bipartition osteotomy. Now, Sherry, how do you think the choice of indication, what should be the choice, and not in this case, but in generally, what are the indications for doing a box osteotomy, spectacle osteotomy, or a facial bipartition?
When you do a bipartition, you're not disturbing the dentition because you're not cutting below especially the deciduous dentition. Especially these children are in mixed dentition, so you don't want to disturb those deciduous, which is not permanents which are not erupted. So permanents will be very close to the lobe or the orbit. So in a bipartition, that's not injured. But when you try doing in a spectacle osteotomy or a box osteotomy, you always have a chance of damaging that. So I would take that into consideration to choose that. In a case where the occlusal planes are actually in a
high arch
palate with the occlusal plane is actually like a pyramid. When you correct it, when you do a bipartition, that gets corrected. But if you do it in a case where the occlusal plane is straight and you do a bipartition, you might even make it worse.
Yeah, you're going to increase the transverse dimension of the arch.
So that might be a way you can choose which to choose.
So in this situation where there is a normal palate, normal occlusion, so is it indicated to go in for a bipartition or for a box osteotomy?
A bipartition, looking at the occlusion part of it, if it is okay, then the bipartition will be a problem, because if you tip the whole thing in this fashion, that is, you rotate the skeleton, is when you disturb the occlusion. But if you don't, then the occlusion stays the same. But if you bring it together, the palatal transverse diameter reduces and it collapses. But you could think in terms of, even if you collapse, to later deal with it with an expansion.
Now, coming to the managemental part, of course, you are one of the pioneers who started off with the hypertelorism from the time I knew in my life, Dr. Krishna Shamrao. So, what are the tips and tricks we should really use in managing these sort of very wide hypertelorisms to be corrected?
The one lesson I have learned over the years is A, one surgery may not be enough, and B, don't be very aggressive in that you get the perfect result, especially where you say 4 centimeter medialization is required. I would put the vision before the mission. So I am okay to do it stage wise. You medialize as much as is safe, and then you correct it later and redo the osteotomy. It's okay.
So stage wise means doing the same box osteotomies twice?
Twice, if required. You will end up doing it anyway, eventually.
Okay. The suggestions for doing the bone grafts laterally, is it how much is indicated with the rigid fixation? Do you think that is going to hold in the lateral aspects, or we have to do?
You need to put bone
grafts. Put a lot of bone grafts.
Yeah.
Now, the second thing is the nasoethmoidal sinuses. What is the level of that for them to again re-enlarge and then recreate the hyperthalamic aspects?
The ethmoidal sinuses pneumatize, I don't know, based on their genetic capability. So some of them relapse clinically because of pneumatization of the ethmoids. Some of them relapse less, but all of them do relapse when you operate early.
Sir, mainly because we need a lot of support from the neurosurgery in retracting and giving the good visualization for the anterior cranial fossa. Here, now coming to the level of for the cribriform plate and for avoiding the naso aspect to go for all the foramens and the nerves there. So what are the suggestions you can give for the surgeons? Most important is how to avoid those things at that time to damage any of that.
So I would actually take a bicoronal flap because if I have to go to the base, I really need a big view. I'm not sure with this incision, I would actually be able to go to the cribriform plate level.
I think there is an incision, sir. There is a
bicoronal.
Okay.
The first one is this is the bicoronal dancer. This is only for reducing the soft tissue.
Yeah. So we in that case, if our exposure, I will only say that we have to be very generous with exposure. Let's go with the very big exposure and expose the craniotomy as such. It's planned by Dr. Anil. We go across. We did a big case, and on the only part which was there that probably that what he said that we should keep the vision before the aesthetic correction, and that would probably mean a stage procedure, but it's fine. I think that.
Sure, please.
I just wanted to ask, what is the need of going so posteriorly in the bicornal incision? I mean, you need the anterior part of the frontal lobe. So, I mean, it is going till the cornal suture. So, what's the need of making such a big craniotomy? I mean, you can
that's
smaller bifrontal craniotomy.
Because we
need the bone flap to be taken off from which they can create reconstruct.
I mean, that's the orbital part,
No. We use that bone flap. We do a sagittal split of the bone and use the inner cortex as a bone graft for the lateral fixations wherever the defect. Because there's a huge amount of lateral defect here because we have medialized the orbits. So this much of defect has to be grafted. So now that's where the bone what we are going to take from here. That part we are going to use for grafting.
Got it.
Now, in fact, like we understood the.
Between you and us. Yours is like this, ours is like this.
Now, the real problem is when you look at the growth. Now, we talk about a simple unilateral cleft or a bilateral cleft. We do a simple surgery, the lip and palate, and there is so much of midfacial hyperplasia. Now, this is again a very difficult craniofacial cleft, in fact, involving even the cleft palate. Now, we have done the lip surgery, we have done such a huge amount of bone surgery in the midface, orbits, and the cranial area. Now, after 20 years of age, the growth is nearly normal. So, Dr. Sherry, what is your comments on this? What is the difference what we see here on comparison to a routine normal facial clefts, normal clefts and a facial cleft with such a huge amount of hypertelorism, even though operated, the growth of the face is nearly normal.
No, I really didn't get the question.
No, the difference between a normal cleft lip palate patients where they have a midfacial hyperplasia,
right?
But this is a facial cleft involving even the lip and the palate and the nose and the orbits. Everything
means you're saying because we have two different problems and where it should have been compounded to produce a maxillary hyperplasia,
yes, in this
which is much more.
Much more, but it's not happening in these hypertelorism.
I guess it's not just the surgery or I think it's a mixture of genetic versus environmental factors. So whatever totals up creates a problem is what you get in the end result when the growth is complete. So I don't think we can actually say that because there are two problems, you can have a bigger negative overjet or more retrusion. I don't think we can calculate because even in clefts, we sometimes see that there are some cases which ends up in much more negative overjet than another case which we have minimal overjet or no negative overjet at all, and the growth is fine. So I think it's just a play between the genetic and the environmental and how it outcome comes. So if this person has a good profile and the negative overjet is less, I think we just deal it with just like an orthognathic case.
Madhu, your opinions, please.
Just to add on, I think there are few publications of literature that is quoted. They say that since you operated quite early, that's like 3 years, at the age of 3 years that we did a hypotelorism correction, it does unlock some growth potential. So there are few publications on that. So maybe that compensated for the maxillary insufficiency, which could have happened because there were so many other associated anomalies.
But
You had a cleft lip, you had a cleft palate, and you also had a hypotelorism. But we did address the hypotelorism initially, along with the lip and the palate. So I think that could be one of the reasons where the deformity was not that bad in the adult.
Please, Krishna.
See, hypertelorism per se, unlike craniosynostosis, where you may have a skull base issue, is not a skull base issue actually. In that sense, it's a lateral skull base issue more than a anterior-posterior skull base issue. If you even look at 20-year-old Goslan studies and on cleft lip and palate, some centers have had very minimal rates of orthognathic surgery following cleft lip and palate repair, which means it is possible that you get good mid-facial growth. So which patient will and will not, like Sherry said, is very hard to predict. This guy is doing very well.
So there is, please.
A probable reason that I can think of, because this is if we categorize this as a testier cleft, it's probably testier
Zero.
hyperplasia, testier zero hyperplasia. So probably that could be one of the reasons why the growth is driving the mid-face forward.
So the AP dimension growth is normal in this. But again, if you look at it, like down the years of 20 years, there is quite a degree of relapse in the transverse dimension of the orbits. So there is a relapse again. You can see the hypertelorism, even though on the table, there's a total reduction, in fact, you got it to zero reduction there. But down the line, like once the child has grown to 20 years age, there is a relapse in the transverse dimension that is again here. So is there a specific way we can say that the AP dimension in this facial clefts in hypertelorism, there is no growth defect, but when it coming to the transverse of the orbits, again there is a relapse.
Did we measure the intermediate canthal distance in the CT, and how much was it? I mean, what I want to ask is whether it's a bony relapse or it's just the telecanthus because of the soft tissue.
It's a bony relapse.
I mean, that is what I am asking. Did we measure?
See, again, the bony relapse augments the soft tissue relapse automatically.
So sometimes the bony bone position is absolutely okay, but because of the stretching of the soft tissue, because of this telecanthus, it looks like that patient is hypertelotic. So we have to measure the bony distance first, and then only we will say that is a relapse.
Krishna, like you've seen one of the most long terms, I presume, from the time you have been operating hypertelorism more than 30 years back, the relapse. How do we overcome this relapse? I see that the one which operated 15 years back, 20 years back, when I look them back again now, most of them have certain degree, good amount of degree of relapses. Even though we thought primarily we have corrected everything, the canthal position, everything was tightened, but now I see that down the line, a lot of cases have relapses.
Yeah. So relapse is to be expected, number one. In this case, there is transverse relapse and some orbital dystopia also.
Yes.
But these things happen because growth is unpredictable in the anterior skull base as well, because we have done cephalometrics, which is largely AP. We don't actually have good papers on the anterior skull base in terms of transverse growth and other things. So it's a new area to be studied, but clinically they have relapsed. I agree.
So the only way is to redo them again.
Only the way is to redo them to the amount necessary to make them aesthetics again.
So interestingly, the right side looks little normal to me when compared to the left side. If you see,
yes,
the relapse seems to be also okay. The relapse could have been more.
So I'll try to go to the next case now. Yeah, this is again a very multiple involvement of the facial area that is in a tessier standard 1, then you have a tessier 5 and a 4 and a tessier 7 with the total absence of the ocular contents there. Now here again the question is the timing. When do you think that we should be able to do it as early as possible? Sherry?
I think this has a standard cleft
Yeah.
lip. So I think I think we should be the soft tissue first, just like the cleft lip. And if there is and that goes up to the lower eyelid, if I'm correct. So I think you need to protect the eye. I think that should get the priority because the lid needs to close because exposure keratitis could be a problem. So I think soft tissue in terms of eye and lip to start with.
Yeah, now again the problem, Krishna, is what we see is even though we are corrected very early as the age of 2 years, 14 years he looks nearly perfectly fine. Down the line, 27 years now, when he ages, you can see that a severe amount of again soft tissue and hard tissue deficiency, even though the good amount of soft tissue approximation, good correction was done primarily. Now, how do we overcome this? How do we predict and overcome these sort of problems?
Overcome is a different question. Predict is a different question. One is there is, I think, muscle hypoplasia in these patients, and therefore, as in clefts, where there is muscle hypoplasia, the results are unpredictable. Some do well, some don't do well. How do you overcome this? I mean, in terms of soft tissue correction, you can do fat augmentation, you can do various things which can make him look nice, but the muscle hypoplasia will remain internally. That won't change. I don't know how his smile is, but that would be interesting to look at as well.
Madhu, what do you suggest, especially in these sort of defects at the infraorbital area? It's a scar puckering area. Now, fat alone will do, or we need to even give any sort of hard tissue augmentations also?
So before that, I would like to know what is this closure, eyelid closure. That is what
he's closing perfectly
because
fine.
I can foresee
sorry,
that
I didn't get the pictures, but his eye closure is perfectly fine.
Because there's some amount of lagging in the inferior lid. So I think the first thing that I would address is make sure I do a canthopexy for him, medially oriented.
Tightening it more.
Yes, tightening. And after that, whatever is a resulting defect in terms of soft tissue, either with a fat, a dermal fat, or even a free tissue transfer, like a muzzle flap, that could be.
So a dermal fat, just a bulk of dermal fat augmentation or microfat injecting also?
It can be both, but a structural fat grafting is what we can think of. A dermal fat also can help in certain scenarios, like just the infra-lid margin. You can still place a dermal fat.
Using the same incision line.
You can use the same incision line.
And then augment.
But you have to use a very good closure, a tight closure, to make sure that it gets incorporated.
Yeah, so that don't pop up again. Yeah. Now again for you, Sherry, because you are one of those gentlemen who is involved in both orthodontics and surgery. Now again we see the growth. Such a deformed facial cleft, but down the line it has palate also. If you see that, there's a palate also is involved here, cleft palate, both. Normal growth. Normal growth.
So why did we get that?
Yes.
It's multiply operated. So like I said, I think it's just that some of them inherently have the potential to grow. What we believe is that they have the inherent potential to grow. You do a surgery on it. The surgery becomes an insult on the growth of the maxilla, and it refuses to grow or reduces the growth. So you end up in a maxillary hyperplasia. They have the inherent growth. The surgery is done, multiple or single, does not affect the blood supply or the growth effect. They end up having normal growth. So I think the monitoring the case as you go gives you an option to actually manipulate the growth as suppose it's the growing skeleton and you see a developing class 3. Can you do a functional appliance to get it right or not? Question number 1. If not, if they're growing well, leave them alone, just manage the dentition. When they reach an adult, you reevaluate again and say, do I need to do anything? Class 1, leave it alone, orthodontics, close.
So now coming to the the real part, like what we have been talking, the last part of the session is on encephalocele now. I think this is where I want my colleague neurosurgeons to really give their inputs. Yes, this is a very interesting case which present to us when the child was 2 years with the frontonasoencephalocele, and then it had quite a significant of bone loss pre-existingly itself. And then these are the scans, what we've seen, and then you can see the herniation of everything, the encephalocele. So we went ahead, did the encephalocele resection, and then we did a very good tight closure with the bony reconstruction as mentioned before in the previous lecture, and everything was done. But the problem is the defect, the frontonasal area defect. Now, okay, we thought we can leave it as the child grows and we can correct it. But now the child is now around 22 years old now, nearly after 20 years of the surgery. We thought this is a reoccurrence. Now, it's not a reoccurrence actually, but there is some sort of soft tissue mass hanging there still. There is no reoccurrence there. And so how do we manage this, what we did primarily, and how do we look forward to do a secondary reconstruction later? Or do you have any method to prevent these sort of major damages happening both for soft tissue and hard tissues, where we can minimize secondary corrections? So,
no, I think that you did a good job in the initial setting, but again, as you're mentioning, it's very difficult to predict at first surgery itself. You said you did it at the age of 2 years around.
Yeah, at the age of 2 years.
Yeah. So probably the surgery would have done much more earlier, somewhere around 9 months to, if the patient comes to in time, 9 to 12 months, about a year or so. But even then, what you have done, I don't think that you could have predicted how it will go. You have excised the ankylosing very nicely. You created a bone around it. The growth pattern you cannot predict. So as and when it happens, you will have to go in and you to correct it. I don't think anybody could have predicted that.
So,
do you want to ask Shailandra?
Yes, sorry.
Also,
yeah, please, Dr.
Yes,
we forgot.
Shailandra, are you around?
Yeah, please.
Yeah, sorry.
Can you switch?
Yeah. Sorry. Can I just see the slides which slightly closely? I'll just kind of the intraoperative photograph. If you can show
Yeah, can we go back to the presentation and show the slides? The slides.
The slides.
What I can see now is from sorry,
initial.
Yeah, initial. Okay. And the next slide.
Yes.
We did a box osteotomy and we reduced the pseudo hypertelorism totally. We did a very fixation, and then also we did a nasal bone augmentation to get the nasal contour there.
It's occasionally means what I have seen is that the skin over the lesion means it has got a, you can't predict as said, because sometimes the signaling problem and the skin over the lesion, you can have a bit of what you call plexiform issues in the thing. You when you see neural tube defects in the back, you can see that there is always some kind of hemangioma or some kind of neurohemangiomatous skin areas. So whether that grows along with the child, and that's why you're getting that. My other question was, she still looks a bit hyperteloric. So whether your reduction from that medial bars of the orbit should have been slightly more aggressive, and getting the canthopaxis secure and bring more medially would have helped. But from the skin point of view, I don't think so you can make any prediction how it will grow, because if there is a genetic issue with a signaling issue, and there is a bit of skin, what you call a neurofibromatosis type of picture, then that excess growth needs to be looked at separately rather than doing anything inside. You probably just have to tidy up the excess growth of the skin, is my thinking.
So anything from your side, sir?
No. I think that's what I completely agree.
Madhu, how do you think we can go for a secondary reconstruction of the frontonasal area now?
So I think you have still spared the supratrochlear and the supraorbital vessels. If you had spared it, then I think we can go for a forehead flap. So that's one still possible paramedian forehead flap.
Can we get the slides, please, again? Because there is still a huge bony defect on the frontal area.
But first I have to ensure that you have good amount of soft tissue there before you can place any bony struct below it.
Yeah.
Because I need a cover, there's so much of scarring there.
Yes.
Which will not be able to, we will not be able to put anything below it in the tight paradigm. So I think the first thing that you need to make sure that you get a paramedian forehead flap, because it's still possible. You haven't, I think, ligated it. Even if you had ligated, it's still the angular vessels which can, perfuse it. So I think first as a paramedian forehead flap, and then once we know that it is completely able to cover it, you can give a rib cartilage grafts in this NOE region. Yeah. So one thing I just wanted to ask you, when we did the completion of the hypertelorism, the box osteotomy in this patient, did we see what was the space that was left behind?
Everything was totally reduced. You can see that there's hardly any amount of medial bar left, very tightened up. Box osteotomy was very tight closed, everything. And then over that,
if you see the third picture,
here,
the third one.
This is the nasal airway going in. This one. Yeah, we reconstruct the floor also with the bone graft there, the anterior cranial fossa.
There's a wire that I can see.
No, that is a wire we put it for the intermediate fixation.
Yeah, exactly. So is there a small space? That is what I was asking.
I think from one angle, if you're looking at it in frontal area, it is totally tightened up. But another thing is, the main problem is there any role of tissue expansion in the frontal area to get a more skin now at this present stage to reconstruct the nose?
Yeah. At this time, I think even a good Sushruta flap will do the job. What could have been done earlier is when you actually did the hypertelorism and reconstructed the nasal bone, since nasal skin doesn't stretch easily. So it's like a serial tissue expansion. You need to put a graft in, which is the same reason why I put a calvareal graft in a Treacher-Collins syndrome, even as they're babies, because it acts as a tissue expander, basically allows things to grow a little bit. So I would have put a little bit more bone initially.
We did put one component of bone there.
Could have put one more probably at that time and allowed the skin to grow a little better.
That's a take-home message for me. Yeah.
And maybe a less amount of skin excision during that time, because you can still do a canthopexy or some kind of a K fixation of these skin paradigms, so that we don't have to excessively remove them
the
and
skin.
Keep them for the later aspect.
Yeah, more tightening
because
of the
the
canthal
child's
ligament.
facial growth was not completed by that time.
The one answer I don't have is almost all these patients have a very long nose eventually. From the nasion till the tip of the nose, it grows long, always. So reconstruction aesthetically is always slightly a problem when they are adults.
So there are two, if I can add, two aspects to it. One is the increased vertical bony height, where the supraorbital rim is more, and another one is the position of the eyebrows. The eyebrows are way far above the eyes.
Yeah.
So even if you get the supraorbital bar and the rim down, the apparent length of the nose will get almost corrected, but the position of the eyebrows, even after all that, will give it away.
Yeah, because it's quite very high.
Yes, it's quite high. Actually, David Chong has a good method of correcting this.
Yeah, what we do is we do a H-shaped incision on the nose, not a vertical incision, but you use two parallel incisions which are in the nasofrontal groove on both sides, and then a vertical incision, so that what you do is get the nose, the aesthetic part of that nose very well. And I can share some slides with you, which I didn't earlier. So if you just check on this and see, hopefully you can see some of them. Full screen. I hope you can see this now. So if you see that, what we do is we kind of get this moving in, and you can see that how we push the nose, and then what we do is pull the tip upwards as well. So when you do that with the incision, this is the earlier part of the series, but later on we started doing that and pulling the tip up, and you can see, and these are long-term outcomes of the patient. These are about 3 years down the line. This is 1 year down the line, but this is now 3 years down the line. Sorry, I'll show you different ones. So you can see that you can achieve a good reconstruction by doing a bit of a vertical or a H-shape incision, depending how you look at it. But what I see the earlier, these are the first series of the first patients we did. And you see what kind of incision you can see. That's kind of a H-shape incision, which pulls everything up, helps them to kind of look different. And we have even done a lot of midline clefts and other surgeries which looked at correcting. What I was saying about the skin is this young man. I think this young man has the same problem as the other one, where the skin is abnormal and it bulges too much. So unfortunately, some of the long noses, it's very inherent that you can't correct it on the first go, but it can be over a period of time that you can look at them and correct them. Sorry, I think there is quite a few which we can look at, but you can achieve good correction by doing a nasofrontal incision, a vertical incision along with the biconal incision, and pull them down. So yeah, it is difficult, but these are the secondary surgeries. So someone has done the first surgery locally, and then we had to go back and correct them. And the kids tend to fall, so I always put them in a helmet, because if they're running around of the reconstruction, they fall down and they just kind of cause more problems. Sorry.
Very nice. Thank you. Actually, these are the things which I started off more than 20 years back. And I think these are the very good take-home message for all of us to catch up how to go forward and improve the quality of surgery. As we've been discussing a lot, it's not about only the resection part, but creating a bed for the future aesthetic component to make them look better. So I think these are a very good take-home message. I would like to thank the organizers, Dr. Suhas and Dr. Pramod, for creating such a wonderful platform on discussing on the encephalocele, hypertelorism, and on facial clefts. Yes, this is one of the very big component for us in an Indian scenario in a craniofacial surgery. I think this also should be taken a major role part for the future.
Yes.
Thank you, all of you. Thank you very much.
Shailendra, thank you so much for joining us.
Thank you. It's been a pleasure always, as I say, coming back.
Are you coming down to India soon, anytime?
I know your Mangalore thing is
need a reason.
mind, so I'll keep saying whether I can try to get some leave and come there. Let's see. I'm hopeful.
Let me know.
Yeah.
Okay.
Thank you, sir.
Thanks.
Thank you, everyone. Thanks for inviting me. And that's a pleasure.
Thank you, Shailendra. So that brings us to the end of the program. We had left a space for any cases that the participants would have liked to discuss, but then we didn't receive any. I thought I will get a few more cases, but then we have run out of time now. I think we will wind it up. Thanks everyone for coming and making
Let's
this.
call it the journey begins here, As Sir was saying, and yesterday we had this collaboration effort. The efforts to collaborate will begin here. We collaborate in terms of science, in terms of research, in terms of education for the future generations, and for all the kids around the country.
Around the world.
Yeah. Thank you.
We can contribute, I think, more even to the world in terms of research. We have more material. I think if we organize ourselves.
More material and the best brains around.
Yes.
Just that we don't get in touch with each other.
There was one study that Irene Matheson presented at Seattle. She had looked at the complication rates associated with delayed extubation in mid-phase cases, in craniofacial cases. So she took data from 6 centers.
Survey, it was survey.
It was a survey, yeah. And then they looked at, various centers had various protocols about some people kept it extubated immediately on table, some people next day and third day. And finally, she said it is better to extubate on table early, because if you prolong, then the chance that they stay on for 3-4 days is higher. So in between, one of the centers changed their protocol from delayed extubation to they moved on to early extubation. So there's so many things that we can do. It's such a simple thought, but beneficial thought. So much we can do. So anybody, any final comments, something?
I think it's time for us to stop talking and get together and make a small organization like we decided yesterday and take this forward, because we need a pan-India presence of craniofacial teams. At least 15 to 20 across India would be able to manage and collaborate. We will get a lot of data, not only in terms of clinical outcomes, but also in terms of the genetic basis rather than just a phenotype, and so many other things, because the sheer volume of cases would give us a stronger presence in the world.
So shall we agree to meet up again, the group, in Mangalore? Because that's where our collaboration with ISCPCA, I mean, we are all members, but within ISCPCA, at least everybody who is interested, let us meet in Mangalore. There will be one day pre-conference exclusively for craniofacial. So if you let us know your willingness to participate in that, then we will all make the program together and again showcase it to the other members of ISCPCA and probably get more neurosurgeons in. That we will get it done. So pre-conference and then one session on craniofacial for the general audience on day one, preferably in the morning itself. So this will show that we are not just saying, but we have real intent. Is that what we decided, right? 10 committee, then from that 3 core. We can discuss in the group also if everybody agrees, and anybody who wants to volunteer for the member, then they can. And we will take it forward. Or 3 apart from the core members, 10 apart from the core committee. So that will give more involvement. It's like a 10-member EC and 3. Is that okay? So more people can get involved.
I mean, I'd just like to thank 2 days of fantastic discussions, and we thoroughly enjoyed. Thanks, Pramod and Swas, and the whole organizing team.
So many things are time-based. Many things I think we can start creating a
sort of protocols which we all follow. We can start putting it up in form of a booklet or PDF document so that we can probably publish it. This is, have a common website where we put all the protocols for people to, read, people to come across to. We can also have in the same website directory of different people. When people go, they see, okay, this is a craniofacial surgeon in the area around me. It's good for them to have at least some sense of information. At the same time, for the other specialties where we are going to get patient referred. I mean, the clefts and hyperrealism will directly come. What about craniosynostomy, which is the major bulk cases? We have to convince the pediatricians to, that it's not cosmetic anymore. So we can do local licensing and we can tell them that this is what it is. Exactly.
Yeah, registry is there.
that's one of the things that we can develop a national registry. It's not like, we are doing 100 cases and all.
No,
Right?
but
So-
as we keep on adding up, it will start building up.
Yeah, for any problems with registry is the, effort you need to take to put the data in.
Yeah.
So, and you don't have to put in 100 cases. Maybe
Exactly.
2, 1, doesn't matter. Right? So it's not a big effort for each center to, add.
Let's do it.
So we will meet again in Bangalore then.
What are the dates?
I think it's supposed to be 17th to 20th, but then Lok Sabha polls may come up during. Was it?
But I don't think that is.
It's not decided yet, but then there's a
Pre-conference date is 17th and 18th is the first date. So 17th to 20th of April is
April 17, 18.
unless there is a different election clash, which I think will not really happen. I think then we may.
Can we have a group photo?
Yeah.
Dr. Gosla? Dr. Gosla? No, he just went out. Can you call if there's anybody outside? Can we take a group photograph?
Yeah.
The thing is, we are going to where he is going to. I can send that sort
Huh?
Really?
We all go where he has gone.
He's just gone out with. You,